हाँ डेविड, यही कोशिश है यार कि काफी क्वेश्चन निकल जाएं तुम्हारे इस बुकलेट से। सारे क्वेश्चंस तो ऑब्वियसली यार 2 घंटे की रेडियो में नहीं हो पाएगा, राइट? बट एटलीस्ट आपका इतना हो जाएगा कि आपका रेडियो रिवाइज हो जाए, बिकॉज ऐसा नहीं होना चाहिए दैट बिफोर एग्जाम यू फॉरगेट अ सब्जेक्ट, राइट? सो द एम ऑफ दिस टॉक इज टू नॉट maybe give you 100% of the radiology questions, but you revise some radiology so that your recall in the exam is better. अगर नहीं पढ़ोगे क्लास में तो रेडियोलॉजी भूल ही जाओगे एग्जाम तक। थोड़ा बहुत देख लोगे तो याद आ जाएगा एग्जाम में। हाउ टू कोरिलेट विद मार्क्स scored in this mock with what we can do in the actual exam? Zero correlation, right? I remember मेरा डैम्स के सीबीटी में, भाटिया के सीबीडी में टॉप 500 भी नहीं थी रैंक, राइट? तब तो कम ही लोग देते थे ये सब सीबीटीज और ग्रैंड टेस्ट और ये सब तो, ठीक है। एंड मेरी टॉप 10 में रैंक्स आई हैं। तो देर इज जीरो कोरिलेशन। आपको बस एंड तक पढ़ना है, यू हैव टू जस्ट रीड टिल दी एंड, यही आप कर सकते हो। हेलो मोहित, प्रणाम। Yes, I'll leave you on time. I'll leave you at 10:30, right? So I've annotated most of the stuff for you already so that we can go a little quickly. I will not bore you with writing a lot of stuff. This is just a revision class. You just listen, right? I'll give you the PDF after the group. You just revise it from the PDF. Just listen, don't write anything. I'll do all the effort for you. You just listen to what I'm talking. आज वाली पीडीएफ बिल्कुल अलग नहीं है, लैब टू का छोटा वर्जन है। लैब टू में थोड़ा एक्स्ट्रा पेजेस डाले थे एक दो, इस वाली पीडीएफ में और कंसाइज कर रखा है। सिली मिस्टेक्स होती रहेंगी यार, सिली मिस्टेक्स से डरो मत। डोंट थिंक दैट यू कैन एस्केप सिली मिस्टेक्स। इवन टॉपर्स डू सिली मिस्टेक्स। यू कैन जस्ट रिड्यूस द नंबर ऑफ सिली मिस्टेक्स। ऐसा नहीं होगा कि आपको जो क्वेश्चन मार्क करोगे श्योर शॉट वो ठीक निकलेगा। सिली मिस्टेक्स सब लोग करते हैं, मैं भी करता हूँ, राइट? बस आप कम कर सकते हो एंड बैलेंस कर सकते हो उन सिली मिस्टेक्स को सम रैंडम इंटेलिजेंट गेसेस से। हाउ टू कैच कीवर्ड्स इन लॉन्ग क्वेश्चंस? सो जो आपने पढ़ रखा है सबसे पहले उन्हीं को देखो कि ये इनमें क्या है। कि अगर पेशेंट फीवर एंड कॉफ के साथ आया है तो मतलब रेस्पिरेटरी प्रॉब्लम है। फीवर एंड कॉफ के साथ आया है पेशेंट तो मतलब रेस्पिरेटरी में इन्फेक्शन के बारे में बोल रहा है वो। अब इन्फेक्शन में देख लो क्या क्या वर्स वर्ड्स हैं। अगर इम्यूनो कॉम्प्रोमाइज लिख रखा है तो डायबिटीज की तरफ, तो फंगल की तरफ जा रहा है पेशेंट। अगर ट्रीन बर्ड नोड्यूल, इवनिंग राइजिंग फीवर, वेट लॉस की तरह लिख रखा है तो टीबी की तरफ जा रहा है। अगर वेट लॉस ही लिख रखा है, लॉन्ग स्टैंडिंग हिस्ट्री लिख रखी है तो कैंसर की तरफ जा रहा है, राइट? तो ऐसे ऐसे बजवर्ड्स आपको देखने हैं। And just tell me, what language are you guys comfortable with? You want me to continue in Hindi or you want me to start in English? इंग्लिश इंग्लिश, हिंदी हिंदी, हिंदी हिंदी, इंग्लिश इंग्लिश इंग्लिश, ठीक है। सो इंग्लिश हिंदी दोनों बोल रहे हैं लोग, सो विल डू इंग्लिश। पंजाबी नहीं आती है यार। हरियाणवी भी नहीं आती है। कॉकरोच जनता पार्टी भी है हमारे साथ। कॉकरोच जनता पार्टी क्यों दे रही है यार एमसीआई स्क्रीनिंग? मैं हूँ यार सीजेपी के साथ, बिल्कुल। आई एम विद रजीम चेंज। 100% आई एम विद सीजेपी। Okay. So without further ado and without wasting anybody else's time, let's start with today's class. So in today's class, we'll be starting with general radiology and then go on to systemic radiology, nuclear medicine, and radiotherapy. Now, in today's class, if you have to remember something, remember nuclear medicine and radiotherapy, because this is something that nobody else will teach you. Only I will teach you this nuclear medicine and radiotherapy. For everything else, you will have clinical correlation. Some of these topics would have been covered in surgery, medicine, obs gynae, right? So nuclear medicine, radiotherapy, and general radiology में थोड़ा stress देना है. Now let's start first with the CT physics and CT attenuation. That why do structures appear black or white on CT scan? So if some of you have attended my regular class, I give this analogy that our eyes appreciate shades of contrast, right? जैसे आप देखोगे कि पुराने जमाने में जो कैमरा, older times, the cameras used to be very माइल्ड सा शेडी सा फोटो आता था. एंड इन करंट फोन्स इन करंट टाइम्स वेरी कंट्रास्ट इमेज आती हैं, राइट? सो यू लाइक टू सी videos in high resolution and our eyes appreciate that. So our eyes appreciate good image contrast. So the image contrast is ability to differentiate between black and white, right? So if this is the black, my eyes can appreciate this white better than this shade of gray. And this whiteness and blackness is plotted on a CT attenuation scale. So on all X-ray based modalities like X-ray, CT scan, fluoroscopy, we have different shades of gray, right? Don't say 50 shades of gray, ठीक है, मेरा जोक है एंड इस पे कोई हंसेगा नहीं है, बट 50 से बहुत ज्यादा शेड्स ऑफ ग्रे हैं हमारे पास. ठीक है. तो सीटी attenuation, first question comes, what is the scale used? It is known as Hounsfield unit. Next question comes, what is the grading, what is the scale of Hounsfield unit? It is from -1000 to +1000. Third question, what is -1000 annotated as? It is given for air. And -1000 tells me that the structure is very black. And hence, air appears black on CT scan, X-ray, fluoroscopy, everything. Now, +1000 is that for cortical bone. And this +1000 appears very bright. So you will see that bones appear bright on CT scan, on X-ray. Why? Because they have +1000 He. Now, fourth question comes that what is the attenuation value of water? Water is given an Hu value of 0. This question has been asked previously. Now, fifth question comes, fat की attenuation value क्या है? Fat has attenuation value of -100, or you can remember it as a negative Hu. Any structure which has negative Hu in a CT scan, if the question mentions that there is a right renal mass with -60 Hu, you will say that that renal mass has a fat component. So fat containing lesions have negative Hounsfield unit. Next question, what are the fat containing lesions that you have to remember? Number one is ovarian dermoid. Number two is renal angiomyolipoma. Right? Ovarian dermoid is teratoma. Angiomyolipoma is the benign tumor of the kidney. Right? So they have negative Hu. Now, other soft tissues like liver, brain, spleen, kidneys have a positive Hu of +50. And acute bleeds like EDH, SDH, SCH have an attenuation value of 80. That is why bleeds appear hyperdense on a non-contrast CT. Right? Now, cortical bone, I've told you, has +1000 and it appears bright. Now, does anything else has +1000? So, cortical bone, stones, and calcifications. So, when do you say it is a calcification? When do you say it is a stone? Both have calcium. So calcification, we call it when it is in the parenchyma. And we call a similar structure as a stone when it is in a lumen. Like GB, like renal pelvic calyceal system or renal stones, ureteric stones, urinary bladder stones. Like fecalith inside the bowel lumen. This is the difference between stones and calcifications. Both are made of calcium, but one is intraluminal, other one is intraparenchymal. Correct? Now, after that, let's come to our X-ray tube anatomy. This is potential question in your FMG. So, X-ray tube is made of two uh, terminals. One is a negatively charged terminal known as cathode, and another one is a positively charged terminal known as anode. Now, electrons move from negatively charged terminal emitted by negatively charged terminal and hit the positive charge anode target, right? Now, when they hit this anode target, you have an X-ray beam which is produced, X-ray photons. Now, question comes, what is this anode made of? So, anode target is made of tungsten plus rhenium, and cathode is made of tungsten plus thorium, right? Now, they pass through a filter and incident and they strike the patient like this. Now, these X-rays have two properties. One of the property is known as KVP and another property is known as MAS. So for generation of X-rays, we rely on two parameters. This is important for you. Right? This is important for you. What is KVP? What is MAS? What is its importance? KVP is the potential difference between cathode and anode. Higher is the potential difference. Higher is the force with which, the velocity with which the electrons move towards the target. Higher is the velocity of electrons. Higher is the energy of the X-rays produced. So KVP determines what? The energy of X-rays. Clear, boss? MAS is what? MAS is the current flowing in the cathode. Higher is the current flowing, higher are the number of electrons emitted, higher is the number of X-rays produced. So MAS determines the quantity of X-rays or the radiation dose. Very, very important. Dose किससे mainly dependent है? MAS. Energy किससे dependent है? KVP. So if I want to image an obese patient, I'll have to increase the energy of X-ray. So I will increase what? I will increase the KVP, because KVP is energy, is the penetration power of X-ray. Barabar. Now, next important concept is with respect to image contrast. I told you in the starting, image contrast is our ability to differentiate between 50 shades of gray. Right? So if this contrast between black and white is good, my eyes will be able to differentiate it well. So image contrast कैसे correlate करता है? It is inversely proportional to KVP and directly proportional to MAS. So if I increase the MAS, the image contrast improves. If I reduce the KVP, the image contrast improves. Right? Now, problem is that in mammography, I want to image the microcalcification. Microcalcifications are very small calcification, tiny calcifications. So for my eyes to differentiate between microcalcification and normal breast parenchyma, I need a good image contrast. देखिए मुझे HD में देखना पड़ेगा, अल्ट्रा HD में देखना पड़ेगा मैमोग्राफी. Now HD अल्ट्रा HD में देखने के लिए मुझे KVP कम करना पड़ेगा. Why? Because if I reduce the KVP, only then my image contrast will improve and only then I'll be able to see microcalcification. So remember, another important question. Mammography operates at a lower KVP than your chest X-ray tube. Why? Because mammography wants to see microcalcifications which are better visualized on low KVP scale. Clear, boss? Now, seventh important concept in this is with respect to imaging an obese patient. I've already told you, in an obese patient, I want to increase the energy of X-rays because the patient is very mota. So the X-rays have to pass through a big, thick slab of fat. They need more energy. I will have to increase the KVP. It is mandatory for me. But when I increase the KVP according to this equation, the image contrast reduces. So compensatorily, I also increase the MAS in an obese patient to improve image contrast. So question comes, in an obese patient, I'll increase both the KVP and MAS. Although KVP reduces image contrast, increasing KVP is my majburi. It is my mandatory thing. Clear, boss? Now, next is what is the reaction? What is the phenomena which happens at the anode, which results in production of X-ray. So there are two types of phenomena. One is known as a Bremsstraße or a braking radiation, and another one is known as characteristic radiation. Now, question was asked in last FMG that what is the mechanism of X-ray production in an X-ray tube? And the answer there was hitting of fast-moving electrons at the anode, right? Now, imagine this is the nucleus. This is the nucleus of the atom, and there are multiple electrons which are surrounding it. And this is the tungsten target, right? जहां से एक्सरेज बन रहे थे. Now ये हमारा आ रहा है. This is our electron which is coming and hitting it. So if it comes and hits and just passes through the atom, but because of the attraction of the nucleus, it gets attracted and changes its direction, right? आप किसी सुंदर बंदे को देखते हो तो उसकी तरफ मुंह मोड़ के देखते हो, राइट? सो ये इलेक्ट्रॉन भी जब जा रहा था एनोड की तरफ, इसको न्यूक्लियस से प्यार हो गया, इसको न्यूक्लियस से अट्रैक्शन हो गया, एंड इसने अपनी स्पीड स्लो कर ली उसको देखते हुए. Now, when he reduced his speed, his energy also reduced, his kinetic energy also reduced. Now, the difference in kinetic energy, law of conservation of energy says energy has to be preserved. So, this difference in kinetic energy is emitted as an X-ray. And this X-ray is known as braking radiation. So it is a continuous spectrum of X-ray. अगर मैं X-ray spectrum बनाऊंगा, it is a continuous spectrum of X-ray with different energies depending upon how close this electron was to the nucleus and how well is it attracted to the nucleus. And why does Bremsstraße radiation happens? Due to breaking of high-speed electrons by the nucleus. This has been asked. This is a potential question again. Right? Now, characteristic radiation, right? Characteristic radiation is what? Let's say you were going to a place, right? Now, electron was coming to the nucleus. Now, it comes and hits this inner shell electron and kicks it out of the shell. But उसके bodyguard भी बैठे थे. There were bodyguard electrons also in the outer shell. So they kick this incoming electron also and they jump and sit in the inner shell, right? So क्या किया? बाहर का इलेक्ट्रॉन तो इनर इलेक्ट्रॉन को भगाया ही, खुद भी लात मार के बाहर भगा दिया गया इसको. So this difference in shell, this K L to K shell jump electron, whenever this happens, a specific energy of X-ray is emitted. And this specific energy is a characteristic radiation. So two types of radiations are present in an X-ray spectrum. Number one is a braking radiation, which is formed by breaking of high-speed electrons by the nucleus. And second is this characteristic radiation, which are specific energy specific to the element, and they are due to ejection of the K shell electrons. Right? So is this point clear? Two types of radiations are clear. This is a potential question in your FMG this year. Right? Okay. So how does these characteristic radiation appear? They appear like these spikes on a continuous X-ray spectrum. Now let's do a few questions. Image contrast is predominantly determined by KVP. Remember, in an obese patient, first factor we do to improve image contrast is increase KVP because that is a mandatory thing. The second factor which we have to modify is an MAS. Now let's see the important investigation of choices. So for all fluid containing pathologies, right? Fluid containing pathologies like ascites, pleural effusion, my investigation of choice will be an ultrasound. For air containing pathologies like pneumothorax, pneumomediastinum, pneumopericardium, pneumoperitoneum, I will do a contrast CT or a non-contrast CT depending on, so CT scan. For calcifications like renal stones and brain calcifications, I will do a NCCT. There is one exception for a type of stone which we do an ultrasound for. It's a GB stone because gallstones are not made of calcium. What are the gallstones made of? Pigmented stones. They're made of cholesterols or pigments, right? Now, for soft tissues like tumors, ligaments, menisci, Soft tissues, resolution, MRI is the best resolution in soft tissue. Cortex, bone cortical pathologies like fractures, osteomas, C for cortex, C for CT scan. Bone marrow pathologies like bone marrow edema, sacroiliitis, stress fractures, osteomyelitis, M for marrow, M for MRI. Now, acute hemorrhage like EDH, FDH, SCH, NCCT. Chronic and micro hemorrhages, we do an MRI. Now, question comes in MRI, what are the chronic hemorrhages? Which diseases do we see chronic hemorrhages? It is diffuse axonal injury and CNS vasculitis. For this, we do MRI, and sequence of choice for this is FWI. Is the sequence of choice. Now for vascular pathologies, now this is one type, this is one area in which students have some confusion, that when do we do Doppler, when do we do CT angio, when do we do DSA, when do we do MR angio. So remember, for vascular pathologies, what are the vascular pathologies? Stenosis, thrombosis, occlusion, dissection, active bleeder. First modality will be a duplex ultrasound, a Doppler ultrasound. Now, second modality, that is the investigation of choice, for most of them will be CT angiography. So let's say you have peripheral artery disease in the lower limb. First investigation, Doppler ultrasound. If Doppler is abnormal, you will do a CT angiography. There are two exceptions to this rule. One is a carotid artery stenosis, and second is a renal artery stenosis. For both of them, we prefer doing an MR angio over a CT angio. And why is that? Because MR angio can be done non-contrast way as well. In renal artery stenosis, already the kidneys are bad. If I give iohexol or contrast, the kidneys will further shut down. So I want to do a non-contrast MR angio, which is possible in MRI. Now, after CT angio has established whether this is stenosis, thrombosis, dissection, occlusion, the gold standard for everything is DSA. The question has come with respect to your intracranial aneurysms. Intracranial aneurysms, investigation of choice is CT angiography. Gold standard is DSA. Right? So in aneurysm, if there is an aneurysm, we do a coiling. If there is a stenosis, you can do angioplasty and stenting. If there is a thrombosis, you can do a thrombectomy. So DSA, that is why we say it is both diagnostic and therapeutic. Diagnostic and therapeutic. Now let's come to types of contrast. This is very, very important. Easy table. And one question, even if you get it from this table, it's a very high yield. So what are the image contrast that we use? What are the contrast media that we use in radiology? So number one are iodinated contrast, which contain iodine. Now iodinated contrast, two important types you remember. One is diatrazoate and another one is iohexol. Now, as a thumb rule, whenever all is there, जैसे alcohol होता है right? Iohexol, iopamidol, iodixanol, all are non-ionic, and all O8 are ionic compounds. Which one is safer for us? We always prefer a non-ionic over a ionic compound as a thumb rule. Now, iodinated contrast are used in X-rays and CT scans. In X-ray, we can use diatrazoate, but in CT scan, when we give IV contrast, we always prefer non-ionic compounds like iohexol and iodixanol. Now, what is the prerequisite before doing a identity contrast study? Especially before you're doing a IV contrast study, you have to do a RFT to estimate GFR, eGFR calculation. And why is that? Because the side effect of iodinated contrast is contrast-induced nephropathy. And how is it defined? Acute renal failure within 48 hours of administering contrast. That is how it's defined. And hence, if the eGFR of the patient is less than 45 ml per minute, iodinated contrast are avoided. They are avoided. Now, next is gadolinium, and gadolinium is an important compound because this is used in MRI. So, question number one, which is the contrast agent used in MRI? It is gadolinium. How is it given, orally or IV? It is given IV, and because it's given IV, a prerequisite is to again do a RFT to estimate GFR. And why is estimation of GFR important? Because side effect of gadolinium is nephrogenic systemic fibrosis or NSF. Now remember, I'm telling you a little advanced stuff because this was asked in INICT this year. There is something known as class 2 gadolinium compounds. Class 2 gadolinium compounds. They are safe in renal failure. Right? So even with advanced renal failure, you can give class 2 gadolinium compound. Just remember this statement. Okay? So concept ka bhi time nahi, it's not important for you also. Now Sonoview is a new compound which was again asked in NEET PG. So Sonoview is a contrast which is used in ultrasound. It is not a CT or an MRI contrast. It is a contrast which is used on ultrasound and it is given intravenously, right? But the advantage is that it has lung excretion. So it is safe in renal failure. It is safe in renal failure because its excretion is lung excretion. Now, lastly, your favorite barium sulfate. It is the least common compound used clinically. Barium sulfate is used in barium studies like barium swallow, barium meal follow through. It is given orally or rectally. And what are the contraindications in cases of perforation, obstruction, or tracheoesophageal fistula? We do not give barium because barium is water insoluble. Right? So it can cause peritonitis, mediastinitis, pneumonitis, etc. And so in cases of perforation, of tracheoesophageal fistula or obstruction in which you have to give a contrast, what do you give? You prefer giving an iodinated contrast like iohexol and diatrazoate. ठीक है boss, is this point clear? Okay. Now next we'll move to Doppler ultrasound. Doppler ultrasound uses velocity of blood flow and direction of blood flow. So as a thumb rule, if the blood is moving towards my probe, it will appear red. And if it is moving away from my probe, it will appear blue. Right? So there is nothing like arteries will have red flow, veins will have blue flow. No. The flow is direction dependent. Flow towards the probe is red, flow away from the probe is blue. Now, what is the principle? Principle is pulsed echo. And what is the angle of insonation? That is the angle with which the ultrasound beam should strike the vessel wall. It should be less than 60 degrees. Now, in our body, we have two types of blood vessels, veins and arteries. Veins have a normal monophasic non-pulsatile flow. Non-pulsatile means no systolic or diastolic variation. It's a constant flow in both systole and diastole towards the heart. That is a monophasic non-pulsatile. Monophasic meaning only in one direction. That is always towards the heart. There is no reversal which is happening. There is nothing like reversal. Whereas arterial flow is pulsatile. Arterial flow has a systolic and a diastolic component to it. Now in our body, if it is a peripheral artery like limb arteries, upper limb, lower limb, or external carotid arteries, they have high resistance. They have high vascular resistance. So they have a normal triphasic waveform. Triphasic mane, the flow in the early systole flow towards, then there's an early diastolic reversal and then forward flow. So forward flow in systole, early diastolic reversal and then late forward flow. This is the triphasic flow, which is normal for a limb artery. And as the vascular resistance increases, for example, there is stenosis, there is a thrombosis, then the flow becomes biphasic and then it becomes monophasic. So monophasic flow in a peripheral artery is always abnormal. And whenever you get a monophasic flow, let's say in the lower limb arteries, in the upper limb arteries, what do you advise? You advise a CT angio to look for any thrombosis, stenosis, or occlusion. Whereas in a visceral arteries, like those arteries supplying the organs, renal artery, hepatic artery, splenic artery, internal carotid artery of the brain, you have a low resistance waveform. So the blood always flow in the forward direction, both in the systole and diastole. But what is the difference? In the systole, there is a pressure se blood flow. There is a peak. But in diastole, there is a less flow. There is less flow. But it is always above the baseline. It never crosses the baseline. So this is with respect to visceral flow. Now, in a visceral flow, whenever the end organ resistance increases, then you first get increase in S by D ratio. For example, placental insufficiency, end organ resistance increases. Our first sign of placental insufficiency is increase in S by D ratio. Now, as the resistance increases, you have absent end diastolic flow and later on reversed end diastolic. So visceral arteries and peripheral arteries behave very differently. Visceral arteries, you have increase S by D ratio, AEDF, REDF. And peripheral arteries, you have triphasic, biphasic, and monophasic waveform. Monophasic waveform in a peripheral artery is always abnormal. So with that basics, let's start with our systemic radiology. It's very, very easy. We'll do it quickly. Starting with the respiratory system, what is the first image shown to you? You can see that's an X-ray. You can see a radiopacity in the left hemithorax with a meniscus sign. So this is a pleural effusion showing you a meniscus sign. Investigation of choice is ultrasound. How do you differentiate between a collapse and a pleural effusion on X-ray? You look at the mediastinum. If the trachea is pushed to the contralateral side, there is a contralateral mediastinal shift. It is pleural effusion. If it shifts towards the same side, then there is something pulling it like a collapse. Now, infected pleural effusion is known as empyema. And what is the sign that you see on CT scan? It is known as split pleura sign. Investigation of choice for empyema is contrast enhanced CT. And what is the treatment? Treatment is an ICD insertion. Infection, you drain that infection. Now, next disease is pneumothorax. What is pneumothorax? Air in the pleural cavity. And what is the hallmark? That in a normal lung, you would see these branching vessels and they would reach till the periphery. But whenever there is air in the pleural cavity, you will see that there is a part of lung which is more black than the rest of the lung. And how do you classify it as more black? What is the criteria to call it more black? That you do not see any blood vessels here. So absence of bronchovascular marking in a radiolucent area of the lung tells you it's a pneumothorax. And if you are able to see this visceral pleural line, which is highlighted by these white arrows, it is more confirmatory that this is a pneumothorax. Now somebody is asking that sir ribs count करवा दो. ठीक है, question आया हुआ है rib counting पे, so I'll help you count the ribs. You always count the ribs anterior to posterior. So this is the first rib. This is the second rib. This is the third rib. We always count it anterior to posterior. 1, 2, 3. And this is what is rib counting. So going slightly off track, but since one of you asked, so I'm telling you. So pneumothorax, the best X-ray view, let's see for some one-liners. The best X-ray view is chest X-ray. PA view, which is expiratory phase, not inspiratory, expiratory phase. And you see a visceral pleural line, which is diagnostic of a pneumothorax. Now, best investigation or the investigation of choice, because it's an air-containing pathology, the investigation of choice will be a non-contrast CT scan. Now, management क्या है भाई? अगर air है तो air को फोड़ दो. So, if it's a unstable patient, an emergency pneumothorax, unstable pneumothorax, you put in a needle thoracostomy. Where do you put in a needle thoracostomy? In the child anterior mid-clavicular line, second intercostal space, adult mid-axillary line, fifth intercostal space. But if it is a stable patient and you have a pneumothorax, then there is no need to put in a needle immediately. You put in an ICD and drain the air, right? So if it's a stable patient, you put in an ICD, which is always put in the fifth intercostal space, mid-axillary line. Now, ultrasound findings of pneumothorax are important in trauma settings, especially. And what are the findings on ultrasound? If it's a B mode ultrasound, you do not see any lung sliding. Absence of sliding lung is a sign of pneumothorax on B mode ultrasound. Whereas on M mode ultrasound, you have your favorite signs like जो कि सबकी जबान पर एकदम ready है, barcode sign and stratosphere sign. ठीक है जी, तो कैसे बताएंगे कि नॉर्मल लंग में सीशोर साइन होता है कि बारकोड साइन होता है? जब आप खुश होते हो, आप नॉर्मल होते हो तो आप गोवा जाते हो। जब गोवा जाते हो तो आपको वहां पे बीच मिलती है। बीच में क्या होता है? सीशोर होता है। सो नॉर्मली व्हेन वी आर हैप्पी वी गो टू द बीच एंड वी सी अ सीशोर साइन, राइट? बट व्हेन वी आर अनहैप्पी we take a flight and go back home. So we see the stratosphere. That is a stratosphere sign is seen in pneumothorax. Normally we are happy, we go to the seashore, we see a seashore sign. सुनामी सुनामी आ गए तो कुछ नहीं। ठीक है, तो बारकोड कैसे पता करेंगे कि नॉर्मली आपको लंग में, दैट अ गुड क्वेश्चन, हाउ डू से इट्स अ बारकोड और इट्स अ सीशोर? इन अ सीशोर यू विल सी दिस पार्टिकुलर मैटर, राइट? ऐसे किरमिच किरमिच सा लगता है। But in a M mode pneumothorax, let's say there is a air between pleural visceral and parietal pleura, right? And you do an M mode, there is no movement of these, and so you'll get perpendicular parallel lines like these. This tells you it is a barcode sign. It's a barcode sign. ठीक है सर, चलिए। Now few other important spotters. Air fluid level in a pleural effusion tells you it's a hydropneumothorax. Treatment is, what is the treatment of hydropneumothorax? कार्डियोफेंटेसिस क्यों यार? कार्डियोफेंटेसिस क्यों करेंगे? हाँ, ट्रीटमेंट इज आईसीडी। जब भी प्लूरा में फ्लूइड है, एयर है, ट्रीटमेंट हमें आईसीडी करना है, निकालना है फ्लूइड को। नाउ इफ यू सी अ कैविटी विद एयर फ्लूइड लेवल्स, then it is lung abscess. And what is this third sign shown to you? You see a patch of consolidation and you do not see the right heart border. Right? What is this sign? This is the silhouette sign, tells you that the pathology is in the right middle lobe. That pathology can be collapse, consolidation, mass, but silhouette sign tells you that this pathology is in the right middle lobe. All right, let's do some other important spotters. So what is this sign? This is the CT halo sign. Center there is consolidation, and in the periphery there is haziness. Right, like a ground glass. So do you know what ground glass is? You guys know what ground glass is? Right? This is what is a ground glass. Can you see? That some haziness, partially translucent area. This partially translucency, this is what is known as a ground glass, hazy type, right? So if you see similar haziness that in the lung, that is known as ground glassing, right? आज तक बहुत सारे बच्चों को यही नहीं पता होगा कि ग्राउंड ग्लासिंग होता क्या है। हाँ, वही बिल्कुल डॉक्टर साहब, बाथरूम वाली खिड़की वो ग्राउंड ग्लास है, बिल्कुल सही पकड़े। ठीक है, so ground glassing in the lungs tells you that the consolidation is not yet so thick that it is appearing very white. It is hazy, little bit hazy. And in the lungs, with respect to infection, ground glassing tells you it's a fungal infection. Very, very important. Very, very important. ठीक है, कोविड में भी आता है। वेरी नाइस, गुड डॉक्टर आसिफ, कोविड में भी आता है। ठीक है, तो आपके क्वेश्चन में कोविड आएगा या फंगल आएगा? एंड क्लिनिकली आपको क्या दे रखा होगा? यू विल बी गिवन हिस्ट्री ऑफ सम इम्यूनोसप्रेशन, मोस्ट लाइकली अ न्यूट्रोपिनिक पेशेंट, for example patient on hematopoietic stem cell transplant or hematological malignancies. These are the patients who have high risk of developing fungal pneumonia. They are neutropenic and the patient will have fever and cough, right? And if you see this halo sign, center में consolidation, periphery में haziness, then you think of a fungal infection. अगर aspergillosis नहीं भी मार्क कर पाओगे, at least mark some fungal infection, म्यूकोर, हिस्टोप्लाज्मा, aspergillosis, candida, राइट? कुछ फंगल मार्क करके आना क्वेश्चन में। अगर हेजीनेस ग्राउंड ग्लास दे रखा है, न्यूट्रोपिनिया दे रखा है, डायबिटीज दे रखा है, इम्यूनोसप्रेशन दे रखा है। ठीक है बॉस? फ्यू अदर साइंस आर सीन इन फंगल इन्फेक्शन, एयर क्रिसेंट साइन and reverse halo sign or bird nest sign. Reverse halo sign is opposite of your halo sign, that is periphery there is consolidation and center में there is haziness. Center में there is haziness. This is reverse halo sign, reverse ground glass, or a bird nest sign. Where is it seen? Again, it is seen in fungal infections like mucormycosis, COVID-19, organizing pneumonia, and aspergillosis. ठीक है बॉस? चलिए, now monod sign is a fungal ball. You will see a cavity in the lung, and in that cavity, you will see a ball-like structure. This is the fungal ball. Fungal ball. How will you? What are the buzzwords in the question? Clinical feature: patient में past history of TB होगा, not active TB, not active TB. And now the patient will present with hemoptysis. राइट, एक्टिव टीबी नहीं है फिर भी हिमोप्टिसिस हो रहा है पेशेंट को, थिंक ऑफ एस्परजिलोमा. वेरी वेरी इंपॉर्टेंट पॉइंटर. That aspergilloma is one of the causes of hemoptysis in a patient who had past history of TB, because aspergilloma क्या बनाता है, घर बना लेता है अपना, जहां भी पुरानी पुरानी कैविटीज होती हैं. ठीक है, नोमैड है एस्परजिलोस. जहां उसको जगह मिल गई, कोई किसी ने अपना घर छोड़ के भाग गया, कोई डिस्ट्रक्शन करके भाग गया, वो कॉकरोच है, उसने वहां पे जाके अपना घर बना लिया. सो एस्परजिलोसिस हैज हिस्ट्री ऑफ मेकिंग कैविटीज. इट इज अ कोलोनाइजर, इट कोलोनाइजेस कैविटीज. कैविटीज में मिलती हैं टीबी में एंड ब्रोंकिएक्टेसिस में. ठीक है जी. अब कॉकरोचेस वो हो गए हैं, ऑफेंड हो गए हैं इससे. चलो, नेक्स्ट इज फिंगर इन ग्लव अपीयरेंस. दिस इज सीन इन एबीपीए, राइट? ABPA, finger in glove appearance. What will be the buzzwords in the question again? History of asthma, fatigue, chronic cough, weight loss. Right? Fever नहीं होगा. Typically, patient will not have fever because all of these things, chronic cough, fatigue, weight loss, can also see in TB. But TB में क्या होगा? Sputum निकलता है, fever होता है. ABPA is a chronic type of disease, type 3 hypersensitivity reaction to Aspergillus fungus. You see this finger in glove appearance. Next question. What is the name of the criteria? The name of the criteria is Isham working group criteria. And what are the important antibodies that you see in ABPA? Increase in Aspergillus fumigator specific IgG and total IgE increased levels. A very, very important sign of ABPA is HAM or high attenuation mucus. That is, in a non-contrast CT, you will see that the dilated bronchi are filled with a hyperdense structure. Normally, mucus is hypodense, but if it's hyperdense, you suspect that it is a fungal mucin. It is a fungal mucus. This is known as HAM, which is the most specific sign of ABPA. ठीक है सर. चलिए, next let's come to cardiovascular radiology. Again, your favorite thing. All of you love seeing boot-shaped heart, egg on string, figure of 8, snowman's heart. Right? सबका बहुत favorite है ये. So सब लोग बताएंगे. चलिए, boot-shaped heart किसमें मिलता है हमें? TOF में. TOF is the most common cyanotic congenital heart disease. If you're asked which is the most common congenital heart disease, if the question is most common congenital heart disease, तब क्या मार्क करेंगे आंसर? VST. ठीक है, बहुत बढ़िया. VST. क्वेश्चन अगर आता है विच इज द मोस्ट कॉमन साइनोटिक कंजेनिटल हार्ट डिजीज इन नियोनेट्स, नियोनेट में अपन मार्क करेंगे TGA. एंड TGA क्या दिखाते हैं? एगॉन स्ट्रिंग. सो मोस्ट कॉमन ओवरऑल VST, मोस्ट कॉमन साइनोटिक कंजेनिटल हार्ट डिजीज टॉफ, मोस्ट कॉमन साइनोटिक कंजेनिटल हार्ट डिजीज इन नियोनेट स्पेसिफिक TGA. ठीक है, ब्लू बेबी पैदा होते हैं TGA के. दैट्स व्हाई इट्स सीन इन नियोनेट्स. Now, box-shaped heart is seen in Epstein anomaly, and history of lithium exposure will be given to you in the question. And then figure of 8 or snowman sign is seen in supracardiac TAPVC. So this is the supracardiac TAPVC showing you figure of 8 appearance. Right? Agon string is this narrow pedicle which is supporting this enlarged heart like a egg hanging from a thin string. And this box-shaped heart is massive cardiomegaly seen in Epstein anomaly. Right? Okay, let's label few important chambers. So remember, right ventricle is the most anterior chamber. It is just behind the sternum. Right ventricle. Right atrium forms the right heart border. Question comes with respect to left atrium. Where is left atrium present, guys? Left atrium is the posterior most chamber right here. It is just anterior to the trachea and the esophagus. So LA is the most posterior chamber and it forms the base of heart. Question comes, which chamber forms the base of heart? Do not mark right ventricle कि सर वो नीचे है और लेफ्ट वेंट्रिकल कि सर वो नीचे है, नहीं. बेस ऑफ हार्ट इज नोन एज द पोस्टीरियर पार्ट ऑफ द हार्ट. एम्ब्रियोलॉजिकली बेस ऑफ द हार्ट की बात होती है जब बेस ऑफ हार्ट बोलते हैं. दैट इज फॉर्म्ड बाय द लेफ्ट एट्रियम. ठीक है, ये क्वेश्चन गलत करेंगे कुछ बच्चे, तो इसलिए मैं आपको बता रहा हूँ ट्रैपर है. पोस्टीरियर चेंबर ऑफ द हार्ट इज लेफ्ट एट्रियम एंड दैट फॉर्म्स द बेस ऑफ द हार्ट. चलें. Now, pulmonary embolism is an important topic. What are the risk factors? First of all, question में दे रखा होगा आपको कि patient has leg swelling, leg pain. That is history of DVT, which tells you it's a DVT. Then what is the scoring system used? It's the Wells score. And on ECG, what are the changes that you see? ECG पे हमें मिलेगा tachycardia सबसे पहले, RV strain pattern and S1Q3 T3 pattern. ठीक है. Now, investigation of choice for pulmonary embolism is CT pulmonary angiogram. An X-ray sign, you just remember the name of the signs: Hampton's hump, Palas sign, Westermarck signs, and Fleschner's sign. डेविड, क्या नहीं समझ आया हार्ट वाले में, बताओ. No, base is not LA plus RA, it is only LA. RA forms the right heart bottom. Yes, apex is formed by LB. The left ventricle is the thicker chamber and left ventricle forms the apex of heart. आर ए राइट साइड ऑफ द हार्ट में होगा यार. जो भी राइट, ये राइट है पेशेंट का, ये लेफ्ट है पेशेंट का. जो चेंबर राइट साइड में है, सिंपली उसको आर ए मार्क करना है, ज्यादा दिमाग नहीं लगाना हमें. जो पीछे है सबसे, द पार्ट ऑफ द चेंबर विच इज मोस्ट पोस्टीरियर, दैट इज लेफ्ट एट्रियम. रिमेंबर, लेफ्ट एट्रियम इज अ पोस्टीरियर चेंबर ऑफ द हार्ट. ठीक है सर, चलिए नेक्स्ट लेट्स कम टू अर्सा और aberrant right subclavian artery. This has been asked in the exam previously. How will you identify an ursa? On the CT scan, you will see that anterior to the vertebral body, there is a vessel which is going and crossing to the other side. This is ursa, right? A lot of students mark it as esophageal diverticulum, tracheal diverticulum. Remember, trachea से कोई diverticulum आएगा तो that will be air containing. Esophagus से कुछ बाहर निकलेगा तो that will be fluid containing or air containing. If it has contrast within, it has to be a blood vessel. It is aberrant right subclavian artery which causes esophageal compression and results in a dysphagia. This dysphagia is known as dysphagia lusoria. Dysphagia lusoria. Now next is aortic dissection, very, very important. Again, aortic dissection is important for our exams. Aortic dissection, what will be the clinical features? Let's first talk about the clinic. The patient will present to you with chest pain, radiating to the back, and it is tearing type, very sudden onset, shearing type of pain. Hallmark of dissection is an intimal flap. So what is a dissection? That the blood is now flowing between the media, between the vessel wall. So you'll have a true lumen and you'll have a false lumen. True lumen and false lumen. And normally false lumen is bigger than true lumen because in the false lumen, the blood keeps coming in, but there is nothing, nowhere to go out. So blood keeps on collecting in the false lumen. So false lumen keeps on increasing in size, keeps on increasing in size. And that is the problem. That is the problem with dissection. There are two important complications. One is rupture and another one is malperfusion. Because false lumen is increasing in size, it is prone to rupture. And false lumen फट गया तो भाई आपकी फट गई. अगर एओर्टिक डिसेक्शन फट गया तो फट गई. ठीक है, क्योंकि इतना ब्लड होगा, इतना ब्लड लॉस होगा, इतना ब्लड लॉस होगा कि जब तक आप ओटी में ले जाओगे पेशेंट को, पेशेंट विल बी गॉन. ठीक है, खत्म, टाटा बाय बाय गुड नाइट. सो एओर्टिक डिसेक्शन इज अ इमरजेंसी, is an emergency. So, next question, what is the investigation to diagnose? If the patient is stable, you shift the patient to CT scan and do a CT angio. बट इफ द पेशेंट इज अनस्टेबल, भाई बीपी उसका 60/40 चल रहा है, उसको जब तक तुम सीटी में ले जाओगे तब तक उसका राम नाम सत्य हो जाएगा. सो यू हैव टू डू अ बेड साइड इन्वेस्टिगेशन, एंड दैट बेड साइड इन्वेस्टिगेशन इज अ ट्रांस esophageal echocardiography. Right? Bedside, you put in an endoscope in the esophagus, and through the endoscope, you do an ultrasound. There's special type of endoscopic ultrasounds available, which help in doing cardiography, echocardiography. Now, classification is very, very important. Two types of classifications are Stanford and DBK classification, which is more commonly used. It is the Stanford classification, which is more commonly used. It classifies aortic dissection into type A and type B. Type A for ascending aorta involvement. Ascending aorta is involved, right? So now ascending aorta alone can be involved, or the entire aorta along with ascending aorta can be involved. Doesn't matter. Both are type A. And type A, why is it important for us to treat? Because from the ascending aorta, you have coronary arteries which come. And if type A dissection is there, coronary infarction can happen, myocardial infarction can happen, the patient will die on table. Hence, type A is a surgical emergency. You have to repair it surgically. Whereas type B is the one in which the ascending aorta is not involved. And in type B, you just do medical management. Now, if your medical management fails, the patient has malperfusion, or if it ruptures, then you have to do an endovascular treatment. Endovascular treatment. So, ascending aorta not involved is type B. Ascending aorta is involved is Stanford type A. Complications of Stanford type A are myocardial infarction due to involvement of coronary arteries and cardiac tamponade. Clear, boss? Chaliye. Next, let's come to now bone tumors. Now, bone tumor is very, very easy. You have covered it in orthopedics. Dr. Purmera has taught you. So first of all, tell me, have you covered MSK radiology, arthritis, bone tumors? Yes, 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 yes. एन्यूरिज्म कैसा दिखेगा? एन्यूरिज्म कैसे दिखेगा? एन्यूरिज्म विल बी सीन एज एन आउट पाउचिंग. तो अगर, okay, I'll show you. This is a good question. If this is a vessel wall and I see two lumens, or let me draw a cross section. Let me draw a cross section. That will be better. If this is a vessel wall and this is the blood flowing into it, that normally this is our artery. Now, instead of a single lumen, if you see an intimal flap and you see two lumens, and one of the lumen has a brighter color as compared to the other lumen, then it means it's a dissection. Whereas if you see an outpouching, for example, you see an outpouching from a artery, that is what is an aneurysm. That is what is an aneurysm. हाँ, जैसा टायर ट्यूब में बल्ज निकलता है, बिल्कुल सही पकड़े डॉक्टर स्लीपी. ठीक है, जैसा टायर ट्यूब में बल्ज निकलता है वो आपका एन्यूरिज्म है. अब अगर ये एन्यूरिज्म में सारी आर्टीरियल वॉल्स हैं, इंटिमा भी है, मीडिया भी है, एडवेंटिशिया भी है, then it is a true aneurysm, which we see in abdominal aorta in cases of atherosclerosis. But let's say that there was a injury to an artery. Let's say an artery was injured and it started bleeding. जब भी आर्टरी फटेगी तो क्या होगा? ब्लीड होगा. ना ब्लीड हो के क्या हुआ कि कंप्रेशन दिया, नॉर्मली बॉडी का हीमोस्टैसिस एक्टिवेट हुआ, अ फाइब्रिन क्लॉट फॉर्म्स अराउंड दिस ब्लीड एंड उसके चारों तरफ बड़ा सा हेमाटोमा है. राइट? तो अब क्या हुआ कि अब ल्यूमेन में एक छोटा सा एक्स्ट्रा ल्यूमेन आया, बट इट इज ओनली लिमिटेड बाय अ फाइब्रिन clot, fibrin outline. It is very, very fragile. That is known as a pseudoaneurysm. This is known as a pseudoaneurysm. Right? So is this point clear? Difference between a aneurysm and a dissection. I spent a little time so that you guys can relax also. थोड़ा ब्रेक भी मिल जाए ताकि आपको एंड एक डाउट भी क्लियर हो जाए. चलिए, okay, now let's start with MSc radiology quickly. Right, so bone tumors, the most important thing is location, location and location. जैसे कि रियल एस्टेट में सबसे ज्यादा जरूरी होता है कि आपने कौन सी उम्र पे खरीदा रियल एस्टेट एंड कहाँ खरीदा रियल एस्टेट, घर कहाँ लिया, जमीन कहाँ ली, फ्लैट कहाँ लिया, तभी उसका प्राइस बढ़ता है ना. तो बोन ट्यूमर्स में भी सबसे ज्यादा जरूरी है हमारा लोकेशन, लोकेशन एंड लोकेशन. ठीक है. तो एपीफाइसिस में अगर कोई हमें ट्यूमर दिख रहा है, इफ वी सी एन एपीफाइसिस epiphyseal tumor, we have two DDs. And we remember them by the mnemonic ECG. Epiphyseal are two tumors, C and G. Chondroblastoma and giant cell tumor. Then how do we differentiate? C for chondroblastoma, C for child. It happens in child. G for giant cell tumor, G for giants, adults. It happens in adults. Now next is diaphyseal tumor. Diaphysis में अगर कोई ट्यूमर आएगा तो हम तीन ट्यूमर सोचेंगे, osteoidostoma, Ewing sarcoma and adamantinum. Great. Now, metaphysis में for all other tumors, we'll think of metaphysis. Osteosarcoma, chondrosarcoma, osteochondroma, aneurysmal bone cyst, fibrous cortical defect, everything will put it in metaphysis. ठीक है. So let's first see the first type of tumor, that is chondroblastoma. We have read that it happens in epiphysis and it happens in a child. So you can see here that in the epiphysis of tibia, I see a lytic lesion. This is a child. Why this is a child? Because the bone plate, growth plate is not fused. C for child, C for chondroblastoma. Next. Again, I see a lesion in the epiphysis reaching till the joint capsule and extending into the metaphysis. So it's an epimeta lesion, but it's involving the epiphysis. And in the radius, I can see a lytic lesion again reaching till the articular surface. It has these multiple septations which give a soap bubble type of appearance. Yes, yes, you're getting there. It is an adult. Why it's an adult? Because the growth plate is fused. It's not open. So this is a giant cell tumor. Epiphysis, adult, soap bubble appearance. Next is fibrous dysplasia. Location is metadiaphyseal in location. If you have to mark one between meta and dia, choose metaphysis. Barabar. Investigation of choice for fibrous dysplasia is NCCT. And on NCCT, I see a ground glass matrix, a hazy like type of matrix, very hazy type of matrix. Let me show you a ground glass matrix of fibrous dysplasia. ठीक है बॉस, दिख रहा है आपको ये ग्राउंड ग्लास मैट्रिक्स? जैसे बाथरूम का शीशा हेजी हेजी होता है, उस टाइप का ग्राउंड ग्लास है. दैट इज द ग्राउंड ग्लास मैट्रिक्स दैट यू सी इन fibrous dysplasia. And ground glass matrix tells you the matrix of the tumor is fibrous in nature, right? So fibrosarcomas, fibrous dysplasias all will have ground glass matrix. Now, important appearance is known as Shepherd-Crook deformity. Yes, somebody mentioned it in the chat box also. And second important other types of syndromes that you see in fibrous dysplasia. McCune-Albright syndrome has been asked. It is fibrous dysplasia plus precocious puberty plus, what is the third thing? Cafe au lait spots. Okay, good. Second syndrome is Mesobrod syndrome, in which we get fibrous dysplasias with soft tissue myxomas. Now, next is aneurysmal bone cyst. Aneurysmal bone cyst happens in children. It also has soap bubble appearance, but unlike giant cell tumor, it is in the metaphysis of the bone. So you can see the epiphysis separately. You can see a growth plate also, and the tumor is expansile, lytic, and it is causing ballooning of the bone, aneurysm of the bone, hence the name aneurysmal bone cyst. On MRI, what will you get? You will get characteristic blood fluid levels. Now, next is simple bone cyst. Unlike aneurysmal bone cyst, in which we get soap bubble or multi loculated appearance. In a simple bone cyst, I get a simple type of appearance, a unilocular bone cyst. Hence, its other name is unicameral bone cyst also. Simple bone cyst, sometimes it's mentioned in the question as unicameral bone cyst. So you will see a unilocular lesion in the metaphysis. It happens in children and adolescents. And you see this typical fractured fragment, which is floating inside this cyst, known as a fallen fragment sign. And another sign is the hinged door sign. If this fracture fragment gets attached to one of the cortical borders. Next is enchondroma. It's the tumor of hands and feet. So whenever you see a tumor, a lytic lesion in the hands and feet, think of enchondroma. Two syndromes associated with it, Olliers and Maffucci's. In Olliers, we have multiple enchondromas. There is nothing except enchondroma. So you will see one enchondroma here, one enchondroma here, one enchondroma here, here. All phalangeal bones will have one enchondroma in it. This is Olliers. Now, if instead of multiple enchondromas, I also see soft tissue hemangiomas, then that is a Maffucci's syndrome. So Maffucci's has multiple things, right? Mangioma bhi hai and enchondroma bhi hai. Olliers may have only enchondroma. So that is how I used to remember. O for only enchondroma, M for multiple things. Brown tumor is very different. Brown tumor kya hai, sir ji? So brown tumor is, पहली बात किसमें दिखता है बताइए ब्राउन ट्यूमर्स? ब्राउन ट्यूमर इज सीन इन हाइपर पैराथायरॉयडिज्म. यस, गुड. प्राइमरी में ज्यादा कॉमन है कि सेकेंडरी में ज्यादा कॉमन है? इट इज मोर कॉमन इन प्राइमरी एज कंपेयर टू सेकेंडरी हाइपर पैराथायरॉयडिज्म, राइट? उसका दूसरा नेम क्या है? ऑस्टियाइटिस सिस्टिका फाइब्रोसा. फाइब्रोसा सिस्टिका होता है, आई थिंक. ऑस्टियाइटिस फाइब्रोसा सिस्टिका. Remember, this is also seen in metaphysis most commonly. All right. चलिए. Next is osteochondroma, also known as exostosis. So this is hamartomatous growth of your growth plate. So you'll see an extension of the bone growing outwards from the native bone. Remember, it always grows away from the joint and it's in the metaphysis. Now, because it's abnormal growth plate, it stops growing after puberty. If it continues to grow after puberty, it means there is some malignant transformation which has happened in it. Now, what is the sign of malignancy in osteochondroma has been asked multiple times. Cartilaginous cap, thickness more than 2 centimeter is risk sign of malignancy. And multiple exostosis is known as diaphyseal eclasis. Diaphyseal eclasis. So multiple bones you will see exostosis. Now, next is osteosarcoma. Osteosarcoma happens in child of 10 to 20 years of age. This is in contrast to Ewing's. Ewing's happens in 0 to 10 years. Now, osteosarcoma happens in metaphysis. Ewing's happens in diaphysis. The matrix in osteosarcoma is osteoid. So, you will see very bright matrix and this sunburst periosteal reaction. Note here that the lesion here is in the metaphysis. Right? So osteoid matrix, long bones are involved and most common location is the knee. You get sunburst periosteal type of reaction. Another reaction is the Codman's triangle, which is the upliftment of the periosteum. Now chondrosarcoma, unlike osteosarcoma and Ewing sarcoma, happens in elderly. So if I plot the age difference, 0 to 10 कौन सा tumor होगा? Malignant bone tumor. 0 to 10 years में क्या होगा? Ewing's. 10 to 20 years में होगा आपका osteosarcoma and more than 40 years में chondrosarcoma. So elderly chondrosarcoma, very young Ewing's, 10 to 20 years, adolescent it is osteo. Now chondrosarcoma is usually involve the flat bones more than long bones, but if it involves long bones, the metaphysis of the bones are more commonly involved than dia or epi. Now, matrix is chondroid matrix. And how do we identify chondroid matrix? You'll see multiple ring and arc type of calcification, a fluffy, cloudy type of calcification. Now, in the flat bones, it can involve the ribs, scapula, pelvis. and it is the most common primary malignant bone tumor involving the flat bones in adults. तो adults में flat bones का most common primary malignant bone tumor is chondrosarcoma. ठीक है, now let's talk about ankylosing spondylitis. So ankylosing spondylitis, what will be the clinical features? A young male, remember it is a male rather than a female, it will present with backache and morning stiffness, right? So you see that when you wake up from the morning, your back is so stiff, your legs are paining, and gradually as you start working, you go through your day, go about your day, then you see that the stiffness and the pain reduces. This is a typical feature of a inflammatory arthritis like a ankylosing spondylitis. So the first joint to involved in an ankylosing spondylitis is the SI joint. And hence the first finding is sacroiliitis. Remember, this is bilateral and asymmetric type. And sacroiliitis present with buttock pains. Now, gradually from the SI joint, it involves the spine, hence the word spondylitis, right? Now, in the spine, you get multiple signs. So you'll see that the adjacent spines are fused by these syndesmophytes, which give a bamboo type of appearance, right? Then if your interspinous ligament is calcified, that gives a dagger sign. If along with the interspinous, your fascial ligaments are also calcified, you get a tram track appearance. So all these are signs of spine involvement in ankylosing spondylitis: dagger sign, bamboo sign and tram track sign. इन्वेस्टिगेशन ऑफ चॉइस अगर कोई बोले तो क्या मार्क करेंगे? इन्वेस्टिगेशन ऑफ चॉइस इज MRI, and I do a special type of sequence known as STIR sequence to see sacroiliitis. Now, another hallmark of ankylosing spondylitis is enthesitis. Enthesitis is what? The part of the ligaments which attaches to the bones. Ligaments or tendons which attaches to the bones. So at the site of attachment of these tendons and ligaments, there is inflammation, right? So Achilles tendon attached to the calcaneum of the heel. Hence, you see heel pain in cases of ankylosing spondylitis. Plantar fascia, which is a ligament, it attaches to the heel, that gets inflamed, you get heel pain, right? And in the spine, you get two other signs known as shiny corner sign and Anderson lesion. Yes, you're right, Dr. Aman. You see HLA B27 positivity. I've deliberately not written it here because again, this is something you cover it in medicine, pathology, multiple places. Now, rickets and scurvy are two important X-rays. All of you know this. Rickets में दे रखा होगा hand and wrist का X-ray, right? And scurvy में दे रखा होगा आपको knee का X-ray. All of you know signs of rickets: widening of metaphysis, splaying, cupping, fraying, Flanagan, blah blah blah. In scurvy, you will be given a knee X-ray, and you will see that there is peripheral ring epiphysis which is calcified. That is the epiphysis is calcified in the periphery. You will see a white line of Frankel, Trummerfield radiolucent zone, and Pelkin spur, a spur of bone. Can you see this bony spur? This is seen in scurvy. So findings are subperiosteal hemorrhages, Wimberger's ring sign, Pelkin spur, Trummerfield white zone, radiolucent zone, and white line of Frankel. Now, lastly, we'll talk about osteoporosis. Osteoporosis is reduced bone mineral density in the bones. That is osteoporosis. So it is a statistical diagnosis. You do a DEXA scan, which is the investigation of choice, and you calculate T-score. Now, what is T-score? What is T-score? Can somebody tell me? Score after drinking tea. Thickness score? No. Depth? No. तो डेक्सा है तो बोन मिनरल डेंसिटी से कोरिलेट होगा. सो टी स्कोर में हम क्या करते हैं? टी स्कोर में वी कंपेयर द बोन मिनरल डेंसिटी ऑफ द पेशेंट विद दैट ऑफ अ हेल्दी इंडिविजुअल, राइट? तो हेल्दी इंडिविजुअल का लेट से बोन मिनरल डेंसिटी था 20 एंड इस पेशेंट का बोन मिनरल डेंसिटी है 10. So now we compare that as compared to the normal patient's bone mineral density, where does his bone mineral density lie? Below 2.5 standard deviation, between -1 to 2.5, or above -1 standard deviation, right? And that is what is known as a T score. So जितना ज्यादा कम होगा एक healthy individual से T score, उतना ज्यादा osteoporosis होगा, बराबर? So how is it defined? T score less than -2.5 is defined as osteoporosis. Between -1 to -2.5 osteopenia, and more than -1 is normal patient. Right? Z score भी होता है, right? Z score भी होता है, you're right. Z score में हम क्या करते हैं? Z score में we compare the bone mineral density of the patient with that of an age appropriate individual. That gives us the Z score. Which one do we use clinically? We use the T score. Now, second type of score which is used in osteoporosis is the FRAX score. FRAX, as the name suggests, is a fracture risk assessment tool. That based on your bone mineral density, what is the risk of fracture, osteoporotic fracture in you? That is FRAX score. And what is the shape of vertebra? You see a typical fish mouth vertebra, codfish vertebra. That is, the vertebral height is more reduced in the center as compared to in the periphery. Right? This is what is known as a fish mouth vertebra. So with that, we finish our musculoskeletal radiology. Now let's come to neuroradiology. Now neuroradiology, again, your favorite topic, EDH versus FDH. So biconvex shape, concavo-convex shape, crossing the sutures, not crossing the sutures, all of you are very well versed with it. So quickly we'll go through it. EDH is a very high velocity severe trauma. So high impact trauma, lucid interval present, arterial bleed, middle meningeal artery is the most common artery involved. The bleed which is biconvex and limited by the sutures. What are the sutures present here? Frontoparietal and parieto-occipital suture. It does not cross these sutures. Very, very important. But can it cross the midline? Yes, it is outside the dura. It can cross the midline like this. बराबर. But FDH के साथ नहीं है. FDH is below the dura mater. So FDH cannot cross the midline. अगर इसको जाना है तो इसको यहाँ पर ऐसे जाना पड़ेगा. राइट, लक्ष्मण रेखा है इसके लिए. फॉक्स सेरेब्राई से लक्ष्मण रेखा ऑफ एफडीएच डज नॉट क्रॉस द मिड लाइन. बट क्या ये सूचर्स क्रॉस कर लेता है? हाँ, ये सूचर्स क्रॉस कर लेता है. ठीक है. सो एफडीएच कैन क्रॉस द सूचर, कैन नॉट क्रॉस मिड लाइन, एंड इट इज कॉन्केवो कॉन्वेक्स इन शेप. ट्रीटमेंट क्या है भाई? ट्रीटमेंट दोनों में ही हमें करनी है क्रीनिएक्टमी. एंड कब करेंगे जी? इफ मिडलाइन शिफ्ट इज मोर देन 5 mm. हाउ डू वी कैलकुलेट मिडलाइन शिफ्ट? नेक्स्ट क्वेश्चन बताइए, कौन बताएगा? हाउ डू वी कैलकुलेट मिडलाइन शिफ्ट? बरहोल किस में करते हैं? बरहोल ईडीएच में करते हैं. आजकल कोई नहीं करता बरहोल. बरहोल करते थे 50 साल पहले. हाँ, तो हमें मिडलाइन देखना है. मिडलाइन शिफ्ट इज द शिफ्ट ऑफ ब्रेन मिडलाइन फ्रॉम द स्कल मिडलाइन. तो स्कल मिडलाइन इज फ्रॉम द क्रिस्टा गेलाई टू द ऑक्सिपिटल प्रोट्रूबरेंस. यहां से लेके यहां तक एक लाइन बनानी है हमें. ये हुई हमारी स्कल की मिडलाइन. एंड ब्रेन मिडलाइन इज बाय द सेप्टम पेलुसिडम, राइट? एंड देन वी मेजर दिस डिस्टेंस. दिस इज व्हाट इज मिडलाइन शिफ्ट. ठीक है. आप पे यही आपको देखना है मिडलाइन शिफ्ट हो रही है कि नहीं हो रही, बिकॉज ट्रीटमेंट आपको एनसीसीटी का दे के पूछेंगे. दे विल गिव यू द एनसीसीटी ब्रेन इमेज एंड देन आस्क यू द ट्रीटमेंट, राइट? एंड दैट इज व्हाट इज इंपॉर्टेंट फॉर यू टू नो हाउ टू कैलकुलेट मिडलाइन, राइट? सो दिस इज हाउ मिडलाइन शिफ्ट इज कैलकुलेटेड. Now, next is subarachnoid hemorrhage. Subarachnoid hemorrhage is bleeding into the arachnoid, and it appears as a star-shaped bleed. It goes into the cisterns, into the sylvian fissures. So, thunderclap headache, the worst headache of your life, neck rigidity, history, mimicking meningitis, but no fever, right? can have meningeal signs because of meningeal irritation. Most common cause is trauma. Most common cause of non-traumatic SH is berry aneurysm. Most common location of intracranial aneurysms is ACOM-ACA junction. That is the junction between the ACA and the ACOM. And if that is not given in the option, mark ACOM as the answer. Third most important location is PCOM. Investigation of choice for cause of SH in a non-traumatic patient, it is CT angiography, because in a CT angiography, the cause was berry aneurysm, and investigation of choice for berry aneurysm is CT angio. Gold standard is DSA, and treatment is clipping or coiling. When do you do a clipping? If the aneurysmal neck is wide, बड़ी नेक है, तो अगर हम यहाँ पे कॉयल डालेंगे तो भाग जाएगा कॉयल, राइट? क्या करते हैं हम वाइड नेक एनेरिज्म्स में? हम एक क्लिप लगा देते हैं इसमें, यहाँ पे वी पुट इन अ क्लिप, ठीक है? जैसे मैगी का पैकेट खोलते हैं तो एक मैगी बनाई, दूसरी मैगी रह गई अंदर, तो उसमें क्लिप लगा देते हैं हम एक, राइट? तो वैसे ही क्लिप लगा देते हैं एनेरिज्म की नेक पे। बट अगर ये एक नैरो नेक एनेरिज्म है, इफ इट्स अ नैरो नेक एनेरिज्म लाइक दिस, राइट, तो क्या करेंगे हम? यहाँ पे कॉइल डाल देंगे, अंदर एक कैथेटर ले जाएंगे और छल्ले भर देंगे, यहाँ पे कॉइल डाल देंगे, सो दैट इट गेट्स थ्रोम्बोज्ड फ्रॉम विद इन, राइट? सो दिस इज कॉइलिंग, वी डू इट फॉर नैरो नेक, एंड फॉर वाइड नेक वी डू क्लिपिंग, ठीक है? चलिए, नेक्स्ट इज स्टारी स्काई अपीयरेंस. स्टारी स्काई अपीयरेंस इन द ब्रेन is seen in neurocystic sarcosis. Now, in a neurocystic sarcosis, the pathognomonic finding that you will see is this typical scolex. That is a dot within this cyst. This is known as a cyst with dot sign, right? Cyst with scolex. If it's present, you have to mark NCC as the answer. Remember, NCC जब भी क्वेश्चन में दे रखा होगा, तो पेशेंट को फीवर नहीं होगा, उसको हेडेक नहीं होगा. What does NCC present with? It presents with seizures. ठीक है? तो seizures. Now, what are the various stages of NCC? Vesicular stage, colloid stage, granular stage, calcified stage. In which stage do you see ring enhancement? That is the question which is asked. You see ring enhancement in granular stage. Now, TB meningitis, you will again see ring enhancing lesions in the brain. In addition to ring enhancement, you will see enhancement in the basal excisterns. Right? This is tubercular meningitis. Now, TB will present with headache and cranial nerve deficits and weakness. In MRI, you will get basal exudates, tuberculomas, and hydrocephalus. Now, these tuberculomas are ring enhancing lesions like this. ठीक है सर? Now, again, if you see a solitary ring enhancing lesion, कि single एक ring enhancing lesion आपको पड़ा है, then think of abscess. An abscess on MRI, remember, have two features: ring enhancement and diffusion restriction. So, ring enhancement lesion ki, we have till now read three important differentials. One is neurocysticercosis. I told you granular stage mein we get ring enhancement. Another one is tuberculomas, tuberculosis brain. And third is brain abscess. How do we differentiate? So, अगर आपको solitary lesion दे रखा है, a large lesion दे रखा है, large solitary lesion दे रखा है showing ring enhancement, and diffusion restriction present है तो सोने पे सुहागा. But solitary large ring enhancing lesion, mark abscess as the answer. If multiple small ring enhancing lesions are present, then it can be neurocysticercosis or TB. If you see a scolex, it is neurocysticercosis. If you don't see a scolex, it is tuberculoma. It is tuberculosis. ठीक है? Normally, whenever you see a ring enhancing lesion, the next step is usually to do a MR spectroscopy. to do an MR spectroscopy, right? Because in MR spectroscopy, if I see a lipid lactate peak, then that is diagnostic of tuberculoma, right? Lipid lactate. Sorry, I was mute. I'm sorry. So I'm saying if I see a lipid lactate peak on MR spectroscopy, it is tuberculoma. Hence, for a ring enhancing lesion, the next step is to do a MR spectroscopy. ठीक है हाँ बिल्कुल सही डॉक्टर अनमार्क यू आर वेरी राइट दिस लुक्स लाइक अ डेथ स्टार ऑफ डेथ जैसा वेरी नाइस वेरी वेल पिक्ड अप बट देन हाउ विल यू डिफरेंशिएट इट फ्रॉम एसएच this will be a contrast CT or a contrast MRI because you see enhancement in TB. Death of star SH will be a non-contrast CT. Bleed appear hyperdense on a non-contrast CT. Basal exudates appear on a contrast enhanced CT. ठीक है बॉस नाउ ring enhancement lesion I told you 3DDs NCC TB and brain abscess. What if the patient is HIV positive? Then the story changes completely. In an HIV positive patient, if it's a solitary ring enhancing lesion, mark CNS lymphoma as the answer. If multiple ring enhancing lesions are present, then mark toxoplasma as the answer. Toxoplasma ring enhancing lesion typically involve the basal ganglia. Basal ganglia involved. Right? And again, in HIV patients, you can have TB also because TB happens in immunosuppressed patients also. But those ring enhancing lesions will be very small lesions. Now, one important periventricular calcifications is seen in congenital CMV. Other type of brain infection, if you see thalamic involvement, mark Japanese encephalitis is the answer. If you see temporal lobe involvement, mark HSV encephalitis as the answer. ठीक है बहुत अच्छे से जानते हैं सब लोग मुझे ब्रेक नहीं मिलेगा भाई थैंक यू फॉर सेइंग दिस ठीक है ब्रेक नहीं मिलेगा चलो नेक्स्ट वी टॉक अबाउट phacomatoses. So if I see subependymal nodules, that is these calcified nodules below the ependyma, I see these cortical tubers, think of tuberous sclerosis, right? Subependymal nodules, sega, cortical tubers, tuberous sclerosis. And what do we get in the skin in TS? We get ash leaf macules and adenoma sebaceum. If I see multiple acoustic schwannomas, we see by this ice cream cone appearance. I see a tumor coming out from the internal acoustic canal into the CP angle like an ice cream cone. Okay, so this is neurofibromatosis type 2. Bilateral acoustic schwannomas are pathognomonic of NF2. And if I see this tram track calcification in the skull, tram track calcification is seen in Sturge-Weber syndrome. Sturge-Weber syndrome. What do I see in Sturge-Weber? Port wine stain. Okay, now let's talk about cystic lesions in the neck. So if it's the cystic lesion is in the floor of mouth, right, at the level of mandible, then mark it as ranula. If it is below the sternocleidomastoid, mark it as second brachial cleft cyst. So this is the sternocleidomastoid, which is highlighted by green, and this is the cystic lesion, which is highlighted by this orange. This is second brachial cleft cyst. If you see a child, infant, and you see multiple multilocular cystic lesion in the lateral part of the neck, think of cystic hygroma. New name of cystic hygroma is lymphatic malformation. Nobody calls it cystic hygroma nowadays. Lymphatic malformation. Remember, they are multiseptated cystic lesions. Now again, your favorite thumbprint sign is acute epiglottitis. Steeple sign croup. Nasopharyngeal narrowing is adenoid hypertrophy. And increased prevertebral thickness is retropharyngeal abscess. Criteria is that at C2 more than 7 mm thickness, at C7 more than 22 mm thickness. चलिए next now we move on to gastrointestinal tract. GI tract is very easy. Pneumoperitoneum is the first disease that we will talk about. So pneumoperitoneum happens whenever where there is a hollow viscous perforation, right? So gastric ulcer perf, duodenal ulcer perf will present with pneumoperitoneum. Ileum perforation, fecal perforation that we see in tuberculosis, typhoid will present with pneumoperitoneum. How does it present? Clinically, rigidity, rebound tenderness. First investigation that you do, first investigation that you do is erect chest X-ray. And in an erect chest X-ray, what do I see? I see air under diaphragm like this. So this crescent shaped air under diaphragm tells me that it is a free air which has risen up on an erect chest X-ray. Investigation of choice क्या होगा? जब भी bowel perf होगा, I will do a contrast CT with iodinated oral contrast. Why iodinated contrast? Because I want to see from where the contrast is leaking, and that tells me the site of perforation. Why am I doing a iodinated contrast? Why am I not doing barium? Why am I not giving barium? Perforation है, so that is contraindicated. Barium is water insoluble. ठीक है जी, चलिए. Let's talk about various investigations. So barium studies, the compound that we give in barium sulfate, given either orally or per rectally. Contraindication we have read: obstruction, tracheoesophageal fistula, and perforation. Now, if you see contrast in the stomach, in the duodenum, jejunum, and ileum, then that is the entire small bowel opacified. That is barium will follow through. If only the esophagus is opacified, that is barium swallow. If the rectum and the large colon is opacified, that is enema. Now, first we'll talk about esophageal pathology. So again, your favorite topics. So Zenker's diverticulum presents with dysphagia and halitosis. You see a contrast-filled outpouching rising from the posterior esophagus. Posterior esophagus, where between which two muscles? This has been asked. You know it. Between thyropharyngeus and cricopharyngeus, right? Now, what is the surgery that is done? The surgery is a Dollman's procedure. Now, next is your favorite, right? Smooth narrowing of the gastroesophageal junction. This is bird beak appearance, which is seen in achalasia cardia. Here you will have dysphagia more to liquids than solids. Investigation of choice for this achalasia cardia is what? Manometry. And treatment is what? Cardiomyotomy, right? Cardiomyotomy. Now, new treatment for achalasia cardia is what? Heller's myotomy, right? New treatment क्या है बताइए? क्या है न्यू ट्रीटमेंट का नाम फॉर एक्लेसिया कार्डिया? पोएम्स, यस. पर ओरल, पर ओरल एंडोस्कोपिक मायोमेक्टमी सर्जरी. ठीक है. सो पर ओरली एंडोस्कोपी वाले कर देते हैं. गैस्ट्रोएंट्रोलॉजिस्ट इतने एग्रेसिव हो चुके हैं आज के जमाने में कि सर्जन्स का नाक में दम कर रखा है. गैस्ट्रोएंट्रोलॉजिस्ट ने सर्जन की नाक में दम कर रखा है. जो जो सर्जिकल प्रोसीजर्स थे, गैस्ट्रोएंट्रोलॉजिस्ट पहुंच जाते हैं अपना स्कोप ले जाके, किसी को काट देते हैं, किसमें स्टेंटिंग कर देते हैं, कुछ कुछ कर देते हैं. टाइम इज नॉट फार व्हेन गैस्ट्रोएंट्रोलॉजिस्ट विल टेक आउट गॉल ब्लैडर. ठीक है. तो गैस्ट्रोएंट्रोलॉजिस्ट ने कलेजिया कार्डिया भी छीन लिया है सर्जन से. एक टाइम था जब जीआई सर्जन्स एक्लेजिया स्पेशलिस्ट होते थे, राइट? बट अब वो टाइम ही चला गया है. अब पोएम होने लगा है काफी जगहों पर. ठीक है जी, चलिए. Now next is dysphagia more to solids than liquids. Now if you see a shouldering, an abrupt narrowing with irregular outline, this irregularity is very important, right? That what tells me that there is a growth in the lumen and it is a CA esophagus. This appearance is known as rat tail sign. In the investigation of choice, whenever there is growth, you have to do a biopsy. So upper GI endoscopy and biopsy. right? Now, next is, just a minute. ओके, नेक्स्ट इज डिस्फेजिया विद चेस्ट पेन. रिमेंबर, चेस्ट पेन एक के साथ होता है, स्पाज्म में होगा. सो डिफ्यूज डिस्फेजियल स्पाज्म कॉर्क्स थ्रू अपीयरेंस ऑफ इसोफेगस. इन्वेस्टिगेशन ऑफ चॉइसेस अगेन मैनोमेट्री. Right now, next we'll talk about congenital diaphragmatic hernia, clinical features with respiratory distress at birth. And why does it happen? Because there is a defect in the diaphragm and all the bowel loops herniate. Now, it is more common on the left hand side than on the right hand side. And what is the complication of a hernia? Complication is that it will compress the lungs. So the complication is pulmonary hypoplasia. Now, if in the CDH patient you start doing bag and mask ventilation when this patient presents with respiratory distress, what will happen? The bowel will further inflate with air and the respiratory distress will worsen. So, contraindicated is bag and mask ventilation. You have to do an endotracheal tube intubation. Now, bowel obstruction presents clinically with abdominal pain, vomiting, constipation, and abdominal distension. Whenever these four things are present, right? Pain, abdomen, vomiting, obstipation, think of intestinal obstruction. Intestinal obstruction is a clinical diagnosis, right? It is not कि एक्सरे रेडियोलॉजिस्ट बताएगा कि ऑब्स्ट्रक्शन है कि नहीं. आप बताएंगे कि ऑब्स्ट्रक्शन है या नहीं. आप बताएंगे कि पेशेंट ने सुबह से पास किए मोशंस की नहीं. ठीक है, अगर नहीं पेशेंट ने पास किए मोशंस, पेशेंट डिस्टेंडेड है, वॉमिट कर रहा है, एब्डोमेन पेन है, तो है उसको ऑब्स्ट्रक्शन. Now, X-ray is the initial investigation in which we get a step ladder pattern, right? Step ladder sign is what? Multiple air fluid levels like these. Investigation of choice for intestinal obstruction is CECT to see the level of obstruction and the cause of obstruction, whether it is an infection which is causing bowel wall thickening, it's a tumor, or it's adhesions. Adhesions are the most common cause of bowel obstruction. Now, in a bowel obstruction, important is to note the difference between small and large bowel obstruction on X-ray. Small bowel loops are central in location and they show these complete septa which are nothing but valvular conniventis. On the other hand, large bowel loops are in the periphery of the abdomen and they show these incomplete septa which are nothing but hostra which are present in the large bowel. So central bowel loops, complete septa, small bowel dilated, small bowel obstruction. Peripherally dilated bowel loops, incomplete septate, large bowel obstruction, hostrations. Now next we'll talk about intussusception. Clinically, patient will be a child, 6 months to 2 years. Presents with red current jelly stools. Most common type is ileocolic. Investigation of choice in children is ultrasound. Now, what are the important signs? So, if on ultrasound I see a bowel within bowel appearance, that there is an outer bowel and an inner bowel which gives a target sign or a donut sign. Gold standard is barium enema because it is both diagnostic and therapeutic. What are the diagnostic signs? You see a claw sign like this. This claw tells me the level where the intussusceptum and intussuscipiens are present. This is the claw sign, and similar to this is the coiled spring sign. If the contrast tracks in between the intussusceptum and the intussuscipiens, it gives a coiled spring sign. Now, what is the treatment? So the treatment depends upon whether the bowel is perforated or not. If it's not perforated and it's ileocolic in location, you do a reduction either with the help of barium, air, or saline. So you put in a Foley's catheter in the rectum of the baby, inflate the cap so a seal is made, and then start pushing air, right? So what will happen with the pressure of air? This intussusceptum will start reducing backwards. And this is what is known as pneumatic reduction done in non-perforated bowel. But if the bowel is perforated due to long-standing obstruction, then you'll have to do a surgery. ठीक है गाइस, सो थोड़ा सा ओवरवेलमिंग हो रहा है, आई नो सुबह से आप लोग लगे हुए हो. इफ यू वांट आई कैन टेक अ 5 minutes ब्रेक, थोड़ा सा स्ट्रेच कर लो, पानी वगैरह पी लो. नो ब्रेक, नो ब्रेक सर, फिनिश करो, खत्म करो, नो ब्रेक. चलो धीरे धीरे करते हैं, थोड़ा धीरे धीरे करते हैं। हाइड्रेटेड सिस्ट इज कॉज्ड बाय एकाइनोकोकस ग्रैनुलारिस. नाउ एकाइनोकोकस ग्रैनुलारिस हाइड्रेटेड सिस्ट, मोस्ट कॉमन लोकेशन ऑफ हाइड्रेटेड is liver. Second most common location of hydrated is lung. Okay. Now, in the hydrated of the lung, in the of the liver, initially what happens? It is a unilocular stage. A simple cyst, no septations, nothing. This is a hydrated. Now, slowly and slowly, what happens? The endocyst start replicating, multiply करने लगती है वो, and daughter cyst बना लेती है वो. So this forms the honeycomb stage or a CE2 stage. So unilocular stage, the unilocular stage is known as CE1 stage, and this phase has a small scolex lying in the lumen of the cyst, which is known as hydrated sand. Now, when the endocyst multiplies and replicates, it gives multiple daughter cysts. Those daughter cysts gives a honeycomb appearance. Now, when the type 1 cyst detaches the endocyst, that is known as water lily sign. It is a transition phase known as CE3A. And when the CE2 stage transitions, some of the cysts die, they become solid, whereas some of the cysts are cystic. So again, it's a transition phase. So again, it's a CE3B. Then cotton wool appearance is CE4 and calcified stage is CE5. Both of them are inactive stages. Both of them are inactive stages. So honeycomb sign is seen in CE2 stage. Water lily sign is seen in CE3A stage. Hydrated sand is seen in CE1 and calcified stage is CE5. Now Garby stages क्या क्या है? Remember Garby ने classify किया, CE1 को उसने 1 ही रहने दिया, CE3A को इसने 2 बोला, Garby 2, एंड CE2 को उसने बोला 3. राइट. सो 1 2 3 1 3 2 है. 3 2 का 1 से याद रख सकते हो आप, 1 2 का 3, 3 2 का 1 और 1 3 2 ऐसे रख सकते हो, कैसे भी याद कर सकते हो. राइट. बट गार्बी स्टेज इज CE2 इज स्टेज 3. राइट. CE2 इज स्टेज 3. Now treatment is pair. So if it is a unilocular cyst like this, a unilocular cyst, you do a pair: puncture, aspiration, instillation, and then re-aspiration. You puncture the cyst, aspirate the contents, put in a scoliocidal agent like absolute alcohol or hypertonic saline. These agents kill the endocyst and then re-aspirate the scoliocidal agent. But if multiple daughter cysts are present, right, then it is a pair is not feasible because individual cyst में आप थोड़ा पंचर करोगे. So the only treatment then is to take out this cyst entirely. Pericystectomy, enucleation type of surgery, that is known as a pericystectomy. Right. Now we'll go on to GB pathology. So first is the gallbladder polyp. You will see an echogenic lesion in the gallbladder, but it does not show any posterior acoustic shadowing. No posterior acoustic shadowing. And that is how you differentiate it from a gallbladder. More than 10 mm, if this polyp size is there, you have to do a surgery. Now, second is acute cholecystitis. Acute cholecystitis is inflammation of the gallbladder. So what will you see? You will see multiple calculi in the GB. And the gallbladder wall is also thickened. Right? See here how thin the gallbladder wall is. Here how thick the gallbladder wall is. So this tells me that the gallbladder wall is inflamed. ठीक है. So wall thickness more than 3 mm, cholithiasis, pericholecystic halo, and sonography, Murphy's sign. These are signs of acute cholecystitis. Now next is comet tail sign. This comet tail sign is seen in GB adenomyomatosis or GB cholesterolosis. ठीक है. चलो next are bile duct pathologies. For bile duct pathologies, Remember, for bile duct pathologies, the first investigation is an ultrasound. First investigation is an ultrasound, and what do we see on an ultrasound? We see that the CBD is dilated and the intrahepatic biliary radicals are also dilated. So the CBD and the IHBR, intrahepatic biliary radicals, left and right hepatic ducts, they are dilated. That tells you there is some obstruction in the biliary pathway. So what is the next step? The next step is to see what is the cause of obstruction. And so for that, you do an MRCP. And if you see a cause, now you have to relieve that cause. You have to put metallic stents or plastic stents. You have to do an ERCP, right? So in a bile duct pathology, it's like choledocholithiasis, benign biliary stricture. First step is to do a ultrasound, which will show you whether IHBRD is present or not. Then you do an MRCP to see the level and the cause of IHBRD, and then you treat it with the help of ERCP, right? So first investigation is ERCP, which is shown here. You can see an endoscope. If you see an endoscope, mark that investigation as ERCP. And this endoscope is doing what? Cannulating the CBD and opacifying the CBD. Now, what else you can see here? You can see some filling defects. These filling defects are nothing but CBD stones. Again, MRCP is showing you these filling defects, which are black in color here. Again, showing you CBD stones. Now, what is this third image? This third image is showing you multiple strictures and dilatation. Strictures and dilatation. Right? So this is what is known as a beaded appearance. Beaded appearance of biliary tree is seen in primary sclerosing cholangitis and IgG4 disease. Two DTs of beaded appearance of biliary tree. Shali. Next, we'll talk about genitourinary radiology. Now, in GU radiology, the first thing we'll talk about are the various modalities. So IVP, X-ray, MCU, and RG. How do you differentiate? First of all, if you see opacification of the pelvic glacial system, renal pelvis, ureters, and the bladder, then that has to be IVP. Remember, in IVP, you do not see urethra. Very, very important. In MCU, what happens? Maturating cystourethrogram. Cystourethrogram. You have to see cysto, that is bladder, and urethra. Now, sometimes in an MCU, you can also see the ureters and the renal pelvis if there is vesico-ureteric reflux. But normally, in an MCU, do not see ureters or pelvic system. If you are seeing, that is diagnostic of UR. Now in RGU, retrograde urethrogram, you only see urethra. नाम में ही है सारा urethrogram. You only see the urethra and maybe the base of the bladder like this. So first investigation, you guys will tell me, what is this? First investigation, are you seeing any ureter? No. Are you seeing any bladder? No. So this is a plain X-ray. This is a plain X-ray. Right? And what are you seeing? You are seeing hyperdensities in the shape of pelvic glacial system. So this is bilateral Staghorn calculus. Now in the second, what modality is this? Tell me, guys. What is this modality, guys? तो IVP है, हमें pelvic glacial system दिख रहा है. I can see the ureter and I can see the bladder. And what is the diagnosis here? The calyces are medially directed. Right, as if they're meeting each other. Handshake sign, shaking hand sign. Right, so this is the horseshoe kidney shaking hand sign or flower vase sign. Next, what is this modality? I can see the ureter, I can see the PCS, I can see the bladder, I can't see the urethra. So this is not MCU, this is IVP. And one-sided PCS is dilated, other side PCS is normal. So this is right-sided PUJ obstruction. right PUJ obstruction. Now the next modality, what is this modality? I can see the pelvic glacial system, the ureter, the bladder, but not the urethra. So this is an IVP again modality. But what is this sign? This is drooping lily sign. And this is seen in duplicated PCS with obstructed upper moiety. So duplicated PCS means two ureters and the upper moiety of the kidney, the upper ureter is obstructed and hence not opacifying. Only the lower ureter is opacifying, which gives a drooping lily type of appearance. This law is known as Weird-Mayer law. Weird-Mayer law. Now, next is this image has been asked multiple times. Very, very diagnostic, very, very easy question. So you see cystic dilatation of the terminal ends of the ureter with upstream hydronephrosis. This sign is cobra head appearance or adder head appearance seen in ureterocele. Next is medial deviation of the ureters. Normally the ureters, can you see? Normally the ureters are lateral to the spine. They're along the tips of transverse process. But if you see that the ureters are medially directed over the vertebral body, that means there is some retroperitoneal fibrosis which is pulling the ureters. It is retroperitoneal fibrosis. The name of the sign is maiden waist deformity. Right, maiden waist deformity seen in RPF, which can be idiopathic, known as Ormond's disease, or can be caused by IgG4 disease. Next is, what is this modality? I can see the pelvic glacial system, the ureters, the bladder, and the urethra. So can it be IVP? You know, IVP नहीं हो सकता because patient is micturating. So it has to be MCU, also known as VCUG, voiding cystourethrogram. And what is the diagnosis? Vesicoureteric reflux. Next, what is this modality? I can see the bladder, I can see the urethra, but the posterior urethra is dilated. And there is this shelf-like obstruction. The anterior urethra is normal. So this is what is known as keyhole appearance or seen in posterior urethral wall. Posterior urethral wall. Now another spotter is J-shaped or fish hook ureter. Remember, this is seen in retrocaval ureter, J-shape or fish hook ureter. So now all three are plain abdominal X-rays. You cannot see the bladder, you cannot see the ureter. On the first X-ray, the calcifications are in the shape of pelvic glacial system. They are staghorn calculi. In the second X-ray, the calcifications are in the shape of renal cortex. They are cortical calcifications. They are seen in putti kidney. Right? In the third, the calcifications are stippled. Such type of calcifications happen when the medulla of the kidney is only calcified. The cortex is not calcified. This is known as medullary nephrocalcinosis, calcification of the renal medulla, medullary nephrocalcinosis. And one of the important causes of medullary nephrocalcinosis is hyperparathyroidism. Okay. Now, lastly, we'll talk about situation in which blood at meatus is present. And whenever blood at meatus is present, one of the important things that you have to rule out is urethral trauma or urethral injury. Good. Investigation of the choice for urethral trauma is RGU. Right? Investigation of choice for urethral trauma is RGU. Now, if RGU is normal, that means your urethra is normal. The blood is coming from somewhere else. So now you put in a Foley's catheter. Now, in a Foley's catheter, if the blood comes out, that means something is bleeding, either the bladder or the kidneys. So what do? You first do a CECT to rule out bladder injury, to rule out kidney injury. If the CECT shows renal trauma, then you have a source of bleed, treat it. But if the CECT is normal, then still the bladder can be bleeding. An investigation of choice for bladder trauma is CT cystogram. Very, very important. Investigation of choice for bladder trauma is CT cystogram. So this was a situation in which the RGU was normal and our source of bleed was either bladder or kidney. But if the RGU shows you contrast extravasation, contrast leaking, that means your urethra is torn, your urethra is injured. So then you can't put in a Foley's catheter. Foley is strictly contraindicated in urethral trauma. So now you have to do a suprapubic cystostomy. ठीक है, ये पढ़ा है हमने सर्जरी में भी. दिस इज द फ्लो चार्ट दैट वी विल फॉलो. So bladder trauma is of two types: intraperitoneal bladder rupture and extraperitoneal bladder rupture. When the dome of bladder ruptures, the contrast leaks into the peritoneal cavity and it surrounds the bowel loops like this. So this is intraperitoneal bladder rupture when the contrast surrounds the bowel loop. The treatment has to be surgical repair because the peritoneal part of bladder has been injured. Whereas if the extraperitoneal part, like the base, posterior side, they have been injured, retroperitoneum itself is a closed space. Remember, retroperitoneum में अगर कोई bleeding भी होती है तो वो खुद रुक जाती है because retroperitoneum is a closed space. Pressure ज्यादा होता है उसमें, bleeding automatically stops. So even a bladder trauma in an extraperitoneal space will heal on its own, provided you do an adequate urinary diversion. So in an extraperitoneal bladder rupture, the contrast accumulates in the retropubic space of Retzius, in the anterior abdominal wall, in the scrotum, in the penis, right? And here the treatment is wait and watch for the bladder to repair. You do a prolonged Foley's catheterization and wait for its natural recovery. Now, this is what is a membranous urethral trauma. You can see contrast extravasation from the membranous urethra. Now, few cystic lesions of the kidney. If you see an adult with large cysts in the kidney and liver, it is ADPKD. You see Swiss cheese appearance on IVP. ARPKD happens in a child with multiple small cysts and multicystic dysplastic kidney, remember, is unilateral. Both ARPKD and ADPKD are bilateral diseases. Multicystic dysplastic kidney is a unilateral disease. And here we get kidney replaced by multiple cysts, which are large, and they happen in a neonate. Their antenatal findings. Neonate में होती है जब patient बच्चा आता है, right? And this kidney is non-functioning. Multicystic dysplastic kidney. So you'll get an absent nephrogram. ठीक है, last few slides are remaining, right? So just hold on tight. 1, 2, 3, 4, 5, 6. Right? 6 slides are remaining, but only theory, right? Nothing to understand there. So next we'll talk about bilateral angiomyolipoma. If you see fat-containing lesions like these are fat-containing lesions in the kidney. I've already told you, fat-containing lesions in the kidneys in angiomyolipoma. It is associated with tuberous sclerosis. Beer paw sign on kidney, that is the pelvic racial system which is dilated, but the renal pelvis is not dilated. This is xanthogranulomatous pyelonephritis. And if you see an air in the renal fossa, and especially if the patient is immunocompromised or diabetic, then you suspect emphysematous pyelonephritis. Treatment here is urgent drainage, either by a DJ stent or by PCN, percutaneous nephrostomy. And if this fails, then the treatment is nephrectomy. Kidneys भी आती है इस पेशेंट्स की, इतने सिक होते हैं पेशेंट्स, right? Now next we'll talk about pheochromocytoma. What is the sign that you see? Light bulb sign. Investigation of choice to localize pheochromocytoma. This has been asked previously. It's MRI. Investigation of choice to localize extraadrenal pheochromocytoma is DOPA PET. If DOPA PET is not given in the option, mark MIBG as the answer. ठीक है guys, so with that we finish our systemic radiology. Now the important thing comes. अब आते हैं जिससे आपके 2-3 क्वेश्चन आएंगे, रेडियोथेरेपी एंड न्यूक्लियर मेडिसिन. क्या इग्नोर कर रहे हैं यार शुभम? दो घंटे तो चलेगा ना यार, अभी होने वाले हैं बस 2 घंटे, 10-15 मिनट्स में विल फिनिश. अब ब्रेक लेके क्या करोगे बताओ? अब ब्रेक दे देंगे तो कैसे चलेगा काम, खत्म करते हैं ना 10-15 मिनट में। So nuclear medicine deals with gamma rays. First of all, let's understand that. So nuclear medicine deals with imaging using gamma rays. अभी तक हम इमेज फॉर्म कर रहे थे यूजिंग एक्सरेज, न्यूक्लियर मेडिसिन में हम इमेज फॉर्म करेंगे यूजिंग गामा रेस। और गामा रेस कैसे बनती हैं? गामा रेस अनस्टेबल न्यूक्लियाई जब टूटते हैं, व्हेनेवर अनस्टेबल न्यूक्लियाई ब्रेक, दे एमिट गामा रेस। सो गामा rays are nuclear in origin. X-rays, how were they forming? When electrons hit the anode, then X-rays were formed. They were extra nuclear in origin. So nuclear medicine uses gamma rays. Now there are three types of nuclear medicine scans. One is a 2D scan, like scintigraphy, which is also known as nuclear scan or radioisotope scan. Then 3D version of this is SPECT, single photon emission tomography. And third is also a 3D modality, that is PET, positron emission tomography. Positron emission tomography. Now, which is the radioisotope that we use to emit these gamma rays? This radioisotope is technetium-99M. Question comes, what does M stand for? M stands for metastable. Just remember this. Now, SPECT में कौन सा radioisotope use करते हैं? In SPECT, we use the radioisotope again same. Technetium-99M radioisotope is same. And PET में we use radioisotope 18 fluorine. 18 fluorine. Now, 18 fluorine is a positron emitter. And what are positrons? Positrons are electrons. They are positively charged particles having mass as electrons, but charge opposite to that of electrons. So, electrons का antimatter है ये. E plus से denote करते हैं positron को. So, जब भी positron अपने नेमेसिस माने इलेक्ट्रॉन से मिलता है, जब भी दुश्मन मिलते हैं आपस में तो क्या होता है? लड़ाई होती है। लड़ाई होती है साउथ इंडियन मूवीज में तो क्या होता है? धूल बहुत इकट्ठा होती है, राइट? धूल बहुत इकट्ठा होती है। सो जब भी लड़ाई होती है पोजिट्रॉन इलेक्ट्रॉन्स में, तो दो ऑपोजिट गामा रेज निकलते हैं 500 इलेक्ट्रॉन वोल्ट के। एंड देन देयर आर डिटेक्टर्स अराउंड द पेशेंट which detect these photons emitting in the opposite direction. So that process is known as annihilation reaction. Whenever positron meets electron, उसके दुश्मन से जब वो मिलता है तो लड़ाई करता है और उसमें एनर्जी निकालता है। ठीक है जी। नाउ टेक्नीशियम 99M की हाफ लाइफ क्या है? अब गलगोटिया यूनिवर्सिटी ने हमारे लिए काम बहुत आसान कर दिया है। वो बोलते हैं कि योर 6 कैन बी माई 9, तो हम बोलते हैं टेक्नीशियम 99M की हाफ लाइफ इज 6 आवर्स। Right? Very, very easy for us to now remember. What does technetium 99M emits? It emits gamma rays. And detector is gamma camera. Now PET में positron emitter है हमारा 18 फ्लोरीन, बट उसको जोड़ते किसके साथ हैं हम? We attach it to a deoxyglucose. And hence the full name of PET is 18 FDG, 18 fluorine deoxyglucose. So 18 fluorine deoxyglucose क्या करता है कि जहां जहां metabolically active cells are there, it gets accumulated there, right? So normal cells glucose लेती हैं, cancer cells because they have high uptake of glucose, metabolically active हैं, they take up this 18 FDG, and वहां से फिर positron निकलने लगता है और फिर उसको ढप्पा कर देता है हमारा डिटेक्टर, right? So this process is known as Warburg effect. And what is the half-life of 18 fluorine? Half-life of 18 fluorine is 110 minutes. Now, what is this test? What test will you do before a PET? I told you that 18 FDG mimics glucose. So, अगर मेरी बॉडी का ग्लूकोज ज्यादा होगा, so कैंसर सेल्स नॉर्मल ग्लूकोज लेंगी, 18 FDG क्यों लेंगी? So, I will do a random blood sugar before doing a PET scan. If my random blood sugar is more than 200, I will not do a PET scan. So, RBF target should be less than 200. So what is the concept of nuclear medicine? There is a gamma emitter, which is technetium 99M. It emits gamma rays, and there is a gamma camera which takes the photo. So wherever this technetium 99M accumulates, gamma rays will start coming out from there and my camera will detect it. So my name of nuclear medicine scans is based on the ligand which take these gamma technetium-99m to its location. तो सेफ्टा में भी कहाँ ले जाता है इसको? सेफ्टा में भी takes this technetium-99m to the parathyroid gland. MIBG takes this technetium-99m to the adrenal gland. MDP takes this technetium-99m to osteoblasts of bone, hence the name bone scan. So let's see the various types of nuclear medicine scans. In the kidney, we have three types of scan: DMSA, DTP, and MAG3. DMSA is used for DMSA, scars, cortical scars. Right? We see cortical scars in vesicular reflex. DTPA is a dynamic scan. We use it in GFR calculation. And remember, captopril DTPA is used in renal artery stenosis. But if you are asked what is the investigation of choice for renal artery stenosis, it is random blood. It is, MR angiography. It is MR angiography. Now, MAG3 is an overall scan because MAG3 is a compound which is secreted both by a glomerular filtration and tubular secretion. So it tells you the overall renal function, and it is used in PUJ obstruction. Now, in PUJ obstruction, to differentiate between partial and complete PUJ obstruction, we give diuretic as well. So if after giving diuresis, the contrast clears from the pelvic glacial system, it means it's a partial PUJ obstruction. Now, in the cardiac, we have two types of scans. One type detects the perfusion and another type detects the infarct. So if in the coronary arteries, so I've drawn a diagram of coronary arteries. If in the coronary arteries, there is a block, the part distal to it will get reduced blood flow, right? But to compensate for this reduced blood flow, what happens? Some collaterals develop. So this myocardium can either die or these collaterals can sustain it for some time and this myocardium goes to sleep, known as hibernating myocardium, right? So two things helps us differentiate between hibernating myocardium and myocardial infarction. If the perfusion scan shows you a photopenic area, shows you a defect, but viability scan like PET-CT do not show you any photopenia, that means the perfusion is less, but the cells are viable. It's a hibernating myocardium. But if both perfusion scan and PET scan shows you an area of photopenia, a cold spot, that means perfusion भी कम है and infarct भी हो गया है. It is an infarcted myocardium. So perfusion scan कौन से होते हैं? Names are sufficient. Thallium scan, tetrophosmin, Sefton spect, and 13 ammonia PET. ठीक है. Now, myocardial viability, that is the test which tells you myocardial infarction is there or not. The best test for myocardial viability is FDG PET. Another type of scan which is used for myocardial viability is pyrophosphate scan, in which hot spot is seen on MI. Pyrophosphate scan. The third type of scan in the heart is used to calculate the chamber volume, that is the LV volumes. That scan is the Muga scan, multi-gated acquisition. But the best scan to see the cardiac volumes or ejection fraction is MRI. Now in bone, we have MDP scan, which is taken up by osteoblasts. So wherever there is high osteoblastic activity like osteomyelitis, osteoblastic met, stress fracture, Paget's disease, you'll see increased uptake. So in stress fracture, what is the sign that you see? Honda sign, this has been asked previously. We see it in bilateral sacral insufficiency fracture. Cold spot on bone scan is seen in multiple myeloma. Then biliary tract imaging, we use HIDA scan. It is used to diagnose acute cholecystitis, bile leaks, and extrahepatic biliary atresia. For parathyroid adenoma, Sefton scan. Again, Sefton SPECT is better than 2D scan. This we have covered previously also. Meckel's diverticulum, we use a per-technate scan. Remember, per-technate scan is also used in salivary gland imaging to detect Warthin's tumor. Now, for neuroendocrine tumor, we have octreotide scan or somatostatin receptor scintigraphy. The name of the PET for neuroendocrine tumors or carcinoid tumor is Dotanoc PET. Now, in neuroendocrine tumors, remember, poorly differentiated carcinoids show avidity on FDG rather than Dotanoc. Whereas well-differentiated carcinoids, the carcinoids which have the somatostatin receptor, they will show avidity on DOTA knock. Now for pheochromocytoma, we use MIBG scan. The name of the PET is DOPA PET. Now for thyroid scans, we use iodine 123 and this tells you whether the nodule is cold and hot. Between hot and cold nodule, which has higher risk of malignancy, the cold nodules, hence cold nodules are sampled. FNAC is done for cold nodules. कोई ब्रेक नहीं है, सॉरी. So iodine 124 is used in PET scan. It's a radioisotope used in PET scan. Iodine 125 is used in radiotherapy. Remember, it's not used in nuclear medicine, it's used in radiotherapy. And iodine 131 is again used in radiotherapy for systemic treatment of thyroid cancer. तो हमें याद रखना है कि जो आयोडीन के लोअर आइसोटोप्स हैं, लोअर न्यूमेरिकल आइसोटोप्स हैं, दे आर यूज्ड इन न्यूक्लियर मेडिसिन, और हायर न्यूमेरिकल रेडियो आइसोटोप्स आर यूज्ड इन radiotherapy. Now, which other scan you have to remember? Prostate cancer का याद रखिए, PSMA PET. This has been asked previously. This you need to remember. बाकी let's forget. Now, in radiotherapy, remember, radiotherapy is treatment of cancers with the help of radiations, right? Treatment of cancer with the help of radiations. So, three types we can do it. Either external beam, जिसको normally हम सिकाई बोलते हैं. You know somebody who has gotten radiotherapy for cancer, सिकाई बोलते हैं patients को ना कि सिकाई होगी अभी आपकी. तो external beam radiation therapy बोलते हैं. इसका most common agent is X-rays. Remember, most common agent of external beam radiotherapy are X-rays, and they are produced in something known as linear accelerators or LINACs. Now, question again comes: LINACs produce both X-rays and electron beams. X-rays are used in external beam radiotherapy, and electron beams are used in intra-op radiotherapy for superficial tumors like mycosis fungoides. Right? Now, second type of therapy is brachytherapy. Now, brachytherapy में हम क्या यूज करते हैं? We use implants. So, अगर एक ट्यूमर है, इसके अंदर हम implants डालते हैं, कोई rods डालते हैं, कुछ लोग particles डालते हैं, and from within these implants are impregnated with radioisotopes which emit radiations. Right? So, this is permanent implants. Now, question comes: what are permanent implants made of? So, permanent implants are made of gold 198, iodine 125, and cesium 131. Iodine 131. Now, some brachytherapy implants are pure beta emitters. Remember strontium, phosphorus, and yttrium. Then stereotactic radiosurgery. What is stereotactic radiosurgery? If this is a brain tumor and this is a brain tumor, if I just want to burn the brain tumor and I give external radiation, the normal brain will also die, and the tumor will also die, and the patient will also die. So to prevent this from happening, what we do? We give this patient radiation from all directions. So जैसे सोलर कुकर होता है ना कि एक शीशा सारी रेज उस पे फोकस करता है, वैसे ही stereotactic radiation focuses all the radiations towards the tumor. So only the tumor dies, the adjacent tissue does not die. This is known as stereotactic radiosurgery. Now, if the radiations are gamma rays, we call it gamma knife. If the radiations are X-rays, we call it cyber knife. And if the radiations are protons, we call them proton beams. Now, question comes: Bragg peak effect is shown by proton beams. Just remember this. Gamma knife is used in brain tumors, brain pathologies like AVM and trigeminal neuralgia. Cyber knife, which uses X-rays, are used in lung cancer and liver cancers. Now, intracavitary brachytherapy is for CA, cervix, more brachytherapy is for eyelid, lips, and penile cancer. Systemic radiotherapy is for iodine 131. So this is what is your gamma knife. This uses a special type of frame, which is known as this Lexel frame. This is a robotic arm in fiber knife, and this is the Bragg peak effect, which is shown by proton beams. चलिए, फिर that is all, right? Some theoretical things. I'll tell you what all to remember here. Half-life of technetium 99 m, you already know. 123, just reverse these three things. 123, 132 कर लीजिए, half-life मिल जाएगी. 125 की 60 days, 12 into 5. 131 को 3 को हम उल्टा 8 कर सकते हैं, रिवर्स 3 बना के, so half-life is 8 days. And then 18 fluorine की, remember, 110 minutes. Now this is very, very important table. Radio-sensitive and radio-resistant structures. So cell cycle phase, if you're asked what is the most radiosensitive cell cycle phase, it is G2M phase followed by M phase. Resistant is the S phase. Organ sensitive, gonads are sensitive, vagina is resistant. Tissue, bone marrow is radiosensitive. Nervous tissue is radioresistant. Blood cell, leukocytes are sensitive and platelets are radioresistant. Now, eye structure, if you're asked, radiosensitive eye structure, sensitive is lens and resistant is sclera. Tumor, if you're asked, radiosensitive tumor is Ewing sarcoma and resistant tumor is osteosarcoma. ठीक है सर, चलिए. रेडिएशन प्रोटेक्शन के लिए हम दो चीजें यूज करते हैं. लेड एप्रन. क्वेश्चन कम्स की मिनिमम थिकनेस ऑफ लेड should be at least 0.25 mm and most commonly lead thickness is 0.5 mm, which is present. Now, TLD batch is used to measure the radiation exposure to a radiographer or a radiology worker. It worn beneath the lead apron. Now again, radiation doses. Remember the dose of chest X-ray, mammo, IVP, and that is it. Now radiation effects पे थोड़ा time लगा लेते हैं. Radiation effects are those effects which are due to exposure by radiations, as the name suggests, right? So if you're exposed to very high doses of radiation, for example, in a nuclear power plant, when it's blast, a high dose of radiation is emitted, right? So such effects only happen after a particular threshold has reached, right? And only after that threshold, the effects start appearing. Below that threshold, no effects is there. Now, what are these effects? Effects like skin erythema, cataract, alopecia, and infertility. They are deterministic effects. They happen at a very high threshold. All or none. Below that threshold, nothing will happen. After that threshold, things will start happening. And the effect is dose dependent. Jitta zyada exposure, utta zyada effect. Whereas stochastic effects are chance effects. You are exposed to 10 CT scans, you might develop a mutation or a cancer, you might not. Right? There is increased probability, but there is no guarantee that increased exposure will result in that effect. Those are known as stochastic effects. Example include mutations and cancer. Okay, so that is all regarding radiology. Finally, a word about acute radiation sickness, that these effects happen when you're exposed to high doses of radiations. So the first tissue to get affected is the bone marrow, right? That is the most radiosensitive. So the first effect that you have are pancytopenia, acute hematological syndromes. This happens at a low threshold and it is a usually prolonged type of illness. Then things to get affected are the GI tract. So you get vomiting, bloody diarrhea, hematemesis at a higher dose. And then the last to get affected are the brain tissue or the cerebrovascular syndrome at a very high dose. So thank you all. That was all regarding today's class. That was all regarding today's class. I'll share this PDF. सेरेबेलम में मिलेंगे, यस यार, पक्का सेरेबेलम में मिलेंगे. सब लोगों का आपका होगा. क्लियर, डोंट वरी. बस ओवर थिंक नहीं करना है एग्जाम में ना, ओवर थिंक करते हैं बहुत सारे स्टूडेंट्स। आपका टारगेट सिंपल है भाई, 150 क्रॉस करना है, 200 220 कोई कुछ कोई जरूरत नहीं लाने की। हमारा टारगेट है 150 क्रॉस करना, तो इसलिए ओवर थिंक नहीं करना है। जितनी कम सिली मिस्टेक्स करोगे उतने ज्यादा चांसेस होंगे आपको क्लियर करने के लिए। ठीक है, मेरा आशीर्वाद है। 26 को एग्जाम आने वाला है, बस फटाक से ये रिवाइज कर लो, मैं शेयर कर देता हूँ टीम के साथ, वो आपको दे देंगे। ऑल द वेरी बेस्ट। 28 को, सॉरी, 28 को है। ऑल द वेरी बेस्ट फॉर योर एग्जाम, एंड आई विल सी यू ऑन द अदर साइड। इफ यू डोंट नो द आंसर विच इज द मोस्ट प्रोबेबल ऑप्शन, मैं मार्क करता था बी। अगेन आपका हो सकता है डिफरेंट हो, बट आई वुड रिकमेंड बी मार्क करो यार। मतलब देर इज नो लॉजिक, बट आई यूज टू मार्क बी। ओके गाइस, गुड नाइट, ऑल द वेरी बेस्ट, बाय बाय। गुड लक, गुड लक छोटा डॉन, बाय दिनेश, बाय। गुड नाइट, बाय।